A very happy morning to our distinguished delegates, all the staff members and students. I feel most glad to welcome everyone to this much awaited conference. I hope that today inspires ideas and discussions around the ways that we can make new waves of field. It's my great delight to greet you all once again to the 3 days National Conference on the Research Innovations in Pharmacological Research 2024. First and foremost, let me give thanks to the Lord for His unfailing love and His wonderful deeds for mankind. With the blessings of God, once again, a very happy morning to one and all present over here.
We kind-heartedly welcome students and chairpersons to our first session of the conference. We are thrilled to have you all here. Get ready for an exciting and enriching experience ahead. It's my distinct honor and privilege to welcome our esteemed chairperson, Dr. P. Balan, M.Pharm PhD, Professor and Department of Pharmaceutical Chemistry, the Erode College of Pharmacy. It is with great pleasure and excitement that we gather here today to embark on this journey of knowledge sharing, collaboration, and innovation. Let us engage in fruitful exchange, foster new collaborations and contributions to shaping the bright future. Welcome once again. Let us make this conference an unforgettable experience for all. I kindly request Dr. P. Balan to come up onto the stage and take a seat to listen to our esteemed speaker.
It's my distinct pleasure to extend a very warm welcome to Dr. S. Manogaran, M.Pharm PhD, Professor, Department of Pharmacology, the Erode College of Pharmacy, our esteemed chairperson for this conference. We are truly honored to have him join us in guiding the proceedings of this event. I kindly invite Dr. S. Manogaran to have a few words about our distinguished guest, Dr. T. Senkutuvel.
Very good morning to all. I'm very happy to see you all in this beautiful auditorium. First, I would like to thank the management and principal of Shanmugha Institute of Pharmaceutical Sciences for inviting us as the chairperson for this session. I'm very happy to introduce Dr. T. Senkutuvel, Professor, Department of Pharmacology, Pharm College of Pharmacy, Palakkad. He is our colleague also. I know him very well from long time. So he completed B.Pharm in Dr. M.G.R. Medical University and M.Pharm from KLE, Bangalore, and PhD in Annamalai University. He has a lot of experience in pharmacological screening, and he attended several international and national seminars and published a lot of publication in reputed journals. With this small introduction, now we can see the audio visual of Dr. T. Senkutuvel. Thank you.
A great speaker is someone who makes complex ideas simple and simple ideas compelling. With great pleasure, I welcome you to Recent Innovation in Pharmacological Research 2024. Today, we are privileged to have Dr. Senkutuvel, M.Pharm PhD, Professor in the Department of Pharmacology at Pharm College of Pharmacy, Palakkad, Kerala, as our keynote speaker. His wealth and knowledge and experience promises to enlighten and inspire us all. Now let's watch a AV play about Dr. T. Senkutuvel.
Dr. T. Senkutuvel is a dedicated professional with a strong background in pharmacology, currently serving as a professor in the Department of Pharmacology at Pharm College of Pharmacy, Kerala. With excellent communication skills and a passion for hard work, Dr. Senkutuvel is driven by a desire to excel in the field of research. His educational journey is marked by significant achievements. In 2016, he completed his PhD in pharmacy from Annamalai University, where he was awarded a UGC Major Research Project Fellowship. Prior to his doctoral studies, he obtained his master's in pharmacology from KLE University, Karnataka in 2012, securing first class with a score of 68%. During this time, he was a recipient of an AICTE-sponsored QIP fellowship. Dr. Sengutuvel's academic journey began with a Bachelor of Pharmacy degree from Tamil Nadu Dr. M.G.R. Medical University, where he graduated with first-class honors in 2008. Dr. Sengutuvel possessed a diverse skill set, particularly in preclinical and clinical pharmacological research projects. He is an expert in animal handling, conducting animal experiments, bioassay of drugs, and drug evaluation. His proficiency in these areas contributes significantly to his research endeavors and academic pursuits. With his commitment to excellence and a solid foundation in pharmacology, Dr. T. Sengutuvel continues to make valuable contributions to the field of pharmaceutical science and research. In conclusion, Dr. T. Sengutuvel's academic achievements and recognition are a testament to his exceptional talent, dedication, and leadership in the field of pharmacy. His contributions have left an indelible mark on the industry, and we are privileged to celebrate his remarkable journey and achievements today. It's an honor to have him among us today, and I have no doubt that his continued contribution will shape the future of pharmaceutical science for the years to come.
Please join me in extending a warm welcome to Dr. T. Sengutuvel as we eagerly anticipate his insights and perspective on advancement in evidence-based medicine.
Warm good morning. I thank my friend and also this Shanmugha group of institutions, chairman and executive trustee and principal of Shanmugha College of Pharmacy, and my friend as well as my student here working as an associate professor Gopala Sadish Kumar, and vice principal of this institute, Dr. Perumal. And apart from this, both are those who are introduced my performer when I was started my career itself, and also my education when I was joined in my B Pharm. At the time itself, they know about me. May I audible? Yes. Once again, I thank, and also I didn't expect that this much video and where they took this information also, I don't know. And also this picture also, unexpectedly, one of my friend, unknowingly he took and sent to me. I just posted in my FB, that post only here presenting. Everything is unexpected. Once again, and also when introduce my name, because of I originated from Chennai. So they are introducing Sengutuvel, not my name is Sengutuvel. Okay, once again, while pronouncing, my name is Sengutuvel, not Sengutuvel. That is because of this picture model, you all know that what is the famous here. Okay, so before going to start my talk, what this evidence-based medicine. First, we should know what is system of medicine. They are allopathy and as well as Ayurvedic medicine. This allopathy as well as this Ayurvedic medicine whenever we are committed with the treatment, we want to know the definitions of drug. We are all background of pharmacy, everyone know that. What it is says, prevent or cure. Whether it will be useful for the prevention or cure, at any way betterment of the society. That is our ultimate goal. When this topic also unexpected, because when he was asked, I was given related with pharmacological topic. This also pharmacology, but even though what we are expected through the pharmacy profession, that will be alternative animal system. This kind of the title only I was proposed. But the organizing secretary proposed the topic after preparing the pamphlet, everything. He sent it me, sir, this is your topic. So then suddenly I was, okay, evidence-based medicines, what it is, we don't know. But after searching regarding these ideas, even though the Pharm curriculum, those who are in the 4th year or 5th year, they know about this evidence-based medicine. They are having the introduction, simple topic regarding this particular area, it is there regarding evidence-based medicine. Even this allopathy or Ayurvedic medicine, this Ayurvedic medicines, really that is evidence-based medicine. Because Ayurveda, Siddha, and as well as Unani and Naturopathy, these all together comes under the evidence Ayurvedic medicine. Then allopathic medicine. What they are expected, when I was searching regarding this evidence-based medicine, in 1988, they are proposed regarding this. Then 1990 only, they are coming to know regarding this evidence-based medicine. Then it is proposed, and also nowadays, whatever the problem, eradicated from the society through the evidence only. Before going to the topic, when searching the history, when the history was 1988, before we all belongs to Tamil Nadu, we know more about what is the culture, what is the future. Regarding that, the our ancient people itself says regarding that. If you understand that, you can come to understand what is the evidence-based medicine. When the Tirukkural, one separate Maruthuvam, okay, that is having composed with 10 kural, okay, 10 kural. Yeah, everyone understand Tamil, no? Yes? Yes or no? Okay. Because when we are talking regarding the particular language, we used to talk with a particular language, then only we can get the real feeling. Okay, that is very important. So, the வள்ளுவர் எழுதும்போது என்ன சொன்னார்னா 10 குறள் எழுதியிருக்காரு, நோய்னா என்ன, அது என்னன்னு சொல்லியிருக்காரு. The last 3 குறள், very important, you are also in the profession. Okay. First thing, you should integrate. Okay. நோய் நாடி, நோய் முதல் நாடி, அது தணிக்கும் வாய் நாடி வாய்ப்பு செயல். வரதராசனார் என்ன சொல்றாருன்னா, நோய் இது என்று ஆராய்ந்து, because whatever we are going to taking the medicine, before that we should properly diagnose. Okay, what is the disease, that will be, who is the responsible for that? Who is the responsible for diagnostic? Physician. Okay, the doctor is the identified fellows to whatever the disease he is having. Then followed by உற்றான் அளவும் பிணியளவும் காலமும் கற்றான் கருதி செயல். Whenever he's learned the medicine through the 5 years curriculum, not only learning, they cannot give the 100% of effective treatment. Followed by, they should make a practice that should be very important. The 1988, what the research are saying, when the at the time சொல்லி வச்சிட்டு போயிருக்கார். Then last one, those who are in the profession of pharmacy, அவங்களுக்காகவே எழுதினார் அப்பவே. ஓகே, அப்ப இந்த மாதிரி pharmacyங்கிற ஒரு செப்பரேட் ப்ரொஃபஷனே இல்ல. இருந்தாலும் அப்ப அடிஷனலி ஓகே, உற்றாவன் தீர்ப்பான் மருந்தொலை செல்வான் என்று அப்பா நாற்கூற்றே மருந்து. நோயுற்றவன் மீன்ஸ் பேஷண்ட், நோய் தீர்ப்பு மருத்துவன் physician. Then additionally the chemical, then followed by மருந்தை அங்கிருந்து கொடுப்பவன். Okay, that is very important. How much responsibility the physician is having, whatever he is diagnosing, whatever he is returning, the responsibility goes to who? Who all are sitting here? Tomorrow you will be a pharmacist. You should be the responsible person. How will you know that? Knowingly or unknowingly, the physician will be diagnosed properly. It is okay. Sometimes he may not be, because of he is not having that much practice. Even though the pharmacist, you know that what is the disease conditions, accordingly which kind of medicines, whether it may be interact or it will be resolve his problem. This all the aspects he should be focused. So these three things, if you are understand, nothing but my session. Okay, that only the session they are discussed in the evidence-based medicine. Then coming to my topic, what is meant by this evidence-based medicine? Three things is very important. First thing, whatever we are analyzing, three things, the triangular thing, if we want to analyze in the healthcare profession, means the first person is the patient. Then second one, very important one, that will be a physician. Then third one will be an who is produce the evidence regarding the particular criteria. Okay, these three things very important for in the evidence-based medicine. The diagnostic tool followed by patient what he is replying. All the system of medicine and also the body system, it is not a single one. It is a complex. It is related with each other. We cannot predict. Even though all the medicines we are prescribing, this cannot say it's 100% effective for even paracetamol. If you are taking the paracetamol, 95% of the people not having the problem. Even 5% people, they are having the contraindications. Okay, the same kind of all the treatment, all the medicines not suitable for all the people. Okay, in that concept, if the next thing, if after the drug, the physician, whatever he is diagnosing, the patient should convey the thing, what we want to convey, whatever the problems he is facing because of consuming the particular components, whether it is a natural or synthetic. Nowadays, the ICMR also accepted, the last one inaugurated the ICMR, National Institute of Traditional Medicine. Traditional medicine in the sense, whatever our system of medicines already have, that is accepted by the Indian Council of Medical Research. ICMR also started the new research unit. It is called National Institute of Traditional Medicines. Whatever we are traditionally using before, the physician won't written in there. But nowadays they are also accepting if you have the evidence that will be coming under the prescription. Especially one company, the Himalaya, okay, they are totally sorted herbal based medicines. But at least 10% of the precision only they are know to write which medicine is effective, and advantage also is there. Some demerits even that medicines will be very useful to the society. That is very, very important. Then whatever the synthetic medicines harmful, it cannot cure, it has the more side effect. At the time we will go to the alternative medicines. Coming to the point, then what is the evidence-based medicine? The evidence-based medicine is an approach to the medical practice that use the result of the patient care, research and other available objective evidence as a component of clinical decisions making. Okay, the decisions making is very important. Without proper evidence, we cannot making the decisions. Okay, for that concern, if you want to make a decisions, three component is very important. First thing, whenever the physician is going to write, he know about thorough knowledge regarding the molecule, whatever it is synthetic or natural. Then followed by the patient feedback, whether it will be pediatric dose or adult dose or geriatric dose, whatever that, how much the feedback you are getting through that, that will be very important. That one, the people, the patient should care. That is our ultimate goal. Okay, the whatever the healthcare system, whether the physician, whether the nurse, whether the pharmacist, whether the allied health science people, our ultimate goal is we want to give the better treatment for the society. That is the main concept. Similarly, the evidence-based pharmacotherapy, whatever we are talking, pharmacotherapy means it will be comes under all the treatment things comes under the pharmacotherapy, whether the synthetic or natural. Whatever the substance involved to treat the disease, it comes under therapy. That will be defined by the Edman colleagues and also the approach to the particular decisions making, that whereby the clinicians appears the scientific evidence and it will be a strength in support of their therapeutic decisions. Okay, the scientific evidence means what they are mainly. That will be I already told the triangle parameter is very important. That should be three people together, the clinical experts, patients and also the researcher. Before coming to the market, molecule, at least it will take 5 to 10 years when enter into the market. When entering, we should submit the evidence. Then only that society will be accepted. Without evidence, if you are submitting, these molecules will be given. How you can know that? For the researcher, he is making the any procedure or methodology, whatever the things, it should be reliable and as well as reproducible. If I am using the particular methods, that methods will be doing in some other area, the same method I am implemented here, it's not getting the result means that cannot be comes under the good research. Wherever you are doing your research, that methodology, what you are given the result, it should be a particular significance. Then only the along with the clinical experts, whatever the disease conditions, properly diagnosis. Diagnosis in the sense 5 years curriculum, it cannot be. After that, at least 5 to 10 years, he should have the expertise knowledge and also the disease condition also population to populations it will be varied. He should be know the conditions. Whenever if you are living in the high altitude, that time the disease condition is different. If you are coming to the normal area, that time is, if you are going to the any desert area, that condition is different. Even though the physician should know based upon his practice, where is the suitable part. If the dose, everything, whenever you are calculating the dose, even though it should be very important. Next thing, the patient values. That should be, the patient should give the values regarding without hesitations, whatever the things you are given, the proper feedback you should be collected through that. So based upon these three components, only the evidence-based medicines will be, topic will be running. Okay, that will be going to, coming to the market when, if whatever the, now, the clinical phase, they are having the totally 5 phases. Phase 0, phase 1, phase 2, phase 3, phase 4. That phase 4 up to the phase 3, whatever that given by the research evidence. Research evidence in the sense preclinical and as well as 3 stage of the clinical evidence. And the last one, the post-marketing surveillance, that should be given through by the patients. Then only we are coming to know whatever the contraindications because of these molecules, then only the expertise. And also another important thing, the clinical expertise should have the colloquial knowledge as well as good relationship with the populations. Then only they can get the all the detail. Some people they may be expressed, some people they cannot be expressed. You have to identify at the time. So the 3 component is very important for these evidence-based medicines. But the clinical judgment after the treatment, how the patient is, then followed by relevant scientific evidence. If you are doing, some company is selling the particular novel components, he give the evidence to the clinician. Okay, the clinician should evaluate the evidence. Then only they are concluding that the components will be that 80% or 100% reliability, that depend upon the molecule. And also the 3rd components, patient values and also the preference. Values and preference means some persons nowadays, all the people, they are swiping the mobile phone, they can get the knowledge regarding the drug. Some people, they are more comfort with, they know that there is the equivalent also they can identify. Okay, if one person is taking for the particular disease, one brand, that will be, they will see whether the economically and as well as both the things they should analyze. Then they can give the suggestion to the physician, I will be having the better than these medicines. That is very important. At the time, the physician as well as the researcher also should cooperate, and also they give the values of the patient knowledge and also the preference of the drug. Okay, sometimes we can give the whatever we are written in the prescription, the patient may have, then they can give the another medicines because of what the physician is written. But that also we give the values and take the commodities. What is the responsibilities of the 3 peoples, the clinical experts? This will be refers to the clinicians, cumulative experience and also the education and also the clinical skills. These 3 parameters to evaluate the clinicians. Clinicians means all the physicians, how they are handling the patients based upon their cumulative knowledge of the experience through the clinical and also the whether he is the basic or they are having the specialization regarding the particular thing. Nowadays, new branches are started in the universities. That will be based upon the knowledge skill of the clinicians and also the not only text reading experience they cannot have, because the text will be written by someone, whatever his experience, accordingly he may able to written. At last, the clinical skill. That will be various kind of the people you should treat. Then only you are coming to know the clinical skill. Then patient. You all know that the patient bring the enough and also his her own personal preference and also the unique concern. We have the expectations and also the values what he is having. That knowledge we should take it from him. Then only we can integrate the particular concept. Then best research evidence. What's mean by all the research evidence are normally the research itself having the separate topic. That will be the best research evidence in the sense what I already told in that the reproducibility and reliability. That both should be very important for the research evidence. It will be usually found in the clinical relevance as well as research whatever the things that should be becoming using for the particular this evidence-based medicine technology. The evidence whatever we are taking that will be itself does not make the decisions but it can help support the patient care and also the process. Then the patients of the evidence-based medicine is usually the triggered by the patient encounter with the some whatever the needed for that. The three components, the quality of life. These three components will be given the betterment of this evidence-based medicines. When we are going to treat the patient, the quality want to improve. If want to be, whatever this is the common scenario, we want to improve the quality of the students or whatever the things means, first thing, we want to give the exam. Exam only going to conclude that who is the given the better one. 100 students in the class, any one or two only the first and second. How they are distinguished from the others? Because of the betterment answering. The questions, whatever the things about the effect of therapy, that will be very important. Then followed by, there will be a utility of the diagnostic test. The physician, whatever the things, for example, if normally how we measure the BP, everyone first year HAP is passed, okay, how we measure the BP? By using sphygmomanometer, it will be showing normally 120/80. Suppose it will show 150/90 or 150/100. What we used to say, suddenly you will take class 1 drug, otherwise the diuretics or beta-adrenergic blockers, we can able to suggest or not? What we will do? We can suggest directly. No, that is not a proper way. If you are going to the physician must, whatever the BP up to 200, he suddenly won't give. First he will be testing. The testing tool, whether first they can collect the blood, they can analyze. Two tests must be, they will prefer. First thing, your cholesterol level. Then second thing, your kidney function test. These two, they are performed, then only they can diagnose. If the two things not having problem, sometimes it is the pathophysiology of hypertension. Okay, this is the main two functions. That will be a system having the defect. Automatically they will suggest and give. Even these two are normal. What they suggest? The next thing. Okay. If the cholesterol it is normal, then kidney functions also is normal. They can ask the persons to, you should be take some rest. Rest in the sense they can suggest some sedative and hypnotics. Okay, sedative and hypnotics, first thing. first line therapy, you can take rest. They can, before itself, they can analyze some questions. How long you are not sleeping, whether yesterday you did this kind of the work, or past 1 week where you are, whether you are, what is the working conditions. He will explain and ask all the history of the patient. Based upon the history, he may suggest 1 or 2 drugs, even though first if you are going to the any MD, whatever the problem, cardiovascular problem, yes, my concern, we are not directly going to the specialty, it's not advisable. First you should go with the any MD physician. He may suggest if you have this kind of activity, they can refer the specialty, you can go. Otherwise, even I have the BP, directly going to the cardiologist. Cardiologist may know or unknowingly, he may be a well practitioner, even he is having the certificate degree of specialty, but even he is not having that much clinical skill, means the treatment therapy is somewhat wrong. If you going to the experienced MD physician, because it is my evidence, okay, then the COVID situations, we used to go to the physician. Especially one of my friend is the cardiologist. He asked me to take the ECG. The ECG is showing 120 heartbeat, 110. Then automatically he suggests you can take some alpha and beta selective inhibitors. Then after that, after some time, it is having the individual drugs, they are having the own side effect. Then I went to the MD physician. He suggested you can take your blood report. Then only I can able to suggest. Then after some days, he will be given the telmorphaty. It will be act on the blood vessels. Then afterwards, some exercise and also yoga. Then automatically after 6 months, we can withdraw the drug. Then we are enter into the normal life. It is when it will come, if you are reading. I was thinking my friend is the very knowledge in the cardiovascular system. I will be going to the physician. I am consuming this many drugs. It cannot cure. Cannot cure in the sense it will prolong. Prolonging means keep on, we want to consuming. But my knowledge, if you are going to the MD physician, whether he is analyzed all the part of the body, he not only specifically look on that. Even though if any kidney related problem, he cannot suggest directly go to the nephrologist. First line therapy, he will do basic whatever the things. Then only they will be asked you to go for the specialty. That will be an utility of diagnostic test, whatever the advanced test, what preventing and also the not prolonging the treatment. If you going for the advanced diagnostic tools, that will give the betterment result. Based upon the results, they can start the therapy, not from the baseline therapy. They can sometimes the targeted therapy also will be useful. That will be given the conclusion through the utilizing of this diagnostic test. Then progressions of the disease also we should know properly how long he have the problem, whether the 1 year or 1 month or 2 months or 4 months, whatever the things, these all the aspects we should be go through. Then only we are coming to know. Then etiology of the disorders. You all know that what is the etiology of the particular disorder. When it was, where it was, for the go through this COVID-19, the virus, whatever the medicines, whatever the vaccines, these all will be satisfy the society. It cannot work out. Whenever the particular things will be, if you go through that, okay, whenever the 10 years before, 100 years before or 80 years before, this viral problem, whatever the medicines we are giving, whatever the recent marketly drugs, it cannot be worked out because the nature of the virus, the person to person, it will be vary. If you are given the medicine, it will be satisfied in the society, even though vaccination also. Okay, it will be only the satisfaction of the society and populations. The virus will be given immunity through the population, then only it will be eradicated. It at least it will take 3 to 4 years. That scenario only we are faced already, we experienced also. Okay, even though if you are going with the COVID problem, if you admitted in the hospital, the therapy will be 100% successful. How many of them with the severe COVID problem? How many of them reboot? If they have the immunity, they will be back. Otherwise, they will be cannot be. That is because of the medicines, it will be cured. The same times, the physiology as well as etiology we want to go through. Then only we have the guidance. Then particular guidance how we will be. Suddenly these people whenever the COVID time they will be having the containment zone. This and all due to this etiology they can go through. These are the protocols you should follow. Then only you can eradicate the disease. Otherwise it cannot be. That is very important of the diagnostic tool for the particular disease. And also they can, even though system, whatever the system we are having the failures for the cardiovascular or respiratory or kidney, they can go through that. Whether your father or forefather, they are having the particular disorders, it's maybe whether it is worked out, this kind of the medicine. Otherwise, you are prolonging up to the things, they can justify the clinician, accordingly they can suggest. It will be, cannot be, whatever the system disorders, especially for the diabetes mellitus, whatever nowadays, more than 50% of the population, young adults from the age of 30 or 25 also nowadays we are seeing the diabetes mellitus. Because of these suggestions and also the etiology, they cannot properly go through, then only they are guiding and also they given the prescription to the particular patient. Otherwise, if you are not go through the etiology, the diagnosis will be wrong way. Then evidence-based medicines, because of these, all the components will be given the important roles. First thing, whatever the marketed product, they are starting with the molecular research. Whether they are inventing from the natural or synthetic, they are started with that. Then the export models, if adopting the particular molecules, that should be suitable. And also particular advanced technology, that should be given the very helpful to the thing. Then practical skill. I am doing some essays. Then many my students also sitting here. Whenever in the laboratory, they used to say, prepare the stock solution. Especially for the physiological salt solution, we are preparing, they should remember whatever the things, especially for the mixing of the component. The compositions of the physiological salt solution will be, especially for the magnesium chloride also sometimes we are added. And calcium also we are added. If we are suddenly without explaining the students, they are also UG, already studied in the pharmacology. I am talking about my PG students. Whenever ask them to prepare the physiological salt solution, they will go suddenly taking the XRY, the chemicals written by the Kulkarni, they can follow, they can take the weight. Then suddenly put it into the whatever the beaker or whatever we are given, they can suddenly mix. At last, it cannot be clear solution. Without clear solutions, we cannot perform the experiments. We can identify suddenly. We can ask the students how you can mix. Whether that should be, expectation should be there. If when you have the expertise conditions, when you are involved in the research, and hands-on experience is very, very important. Whatever we are reading in the text, that cannot be worked out. You should be involved in that. You have the hands-on experience. Then only coming to, that will be a very minor problem. Whether you are mixing all the component in the single beaker or you are separately mixing the calcium chloride, then put it into the, at last you are mixed with the physiological salt solutions, it cannot be turbid. Even you are taking all the components weight, then mixing directly means it should be a turbid. That is one. The another one thing, if you are using the tap water, automatically this component will be turbid. Especially then apart from this, if you are going to the molecular biology lab, that people always, whatever the students is always students. Okay, whatever we are given, whatever the procedure we are given, they will be just reading. Then one person will be there for the key player of the entire thing. Okay, that person will dictate. Everyone will be act. At last, what he is, the teacher is what he is saying, that will be separate thing. What he is saying, that will be Vedavaka, they will be take. Okay, so they will be doing whatever the instructor is saying. Then whatever the procedure, they don't bother. Then that person, sometimes if he is not having the knowledge, that entire system will be collapsed. Collapsed in the sense, whatever the chemicals, whatever we are putting, that efforts, the chemical waste, at last you cannot get the result also. Okay, that is the thing. Then that knowledge, that will be, comes under that practitioner skill. Very even not only for in our, I am saying simple example for us. That will be very important skill for the physician also. They should be properly diagnosed, then only they can coming to get the particular knowledge. How many of them know the ringer lactate, how they are invented? Are a pharmacy student? Pharmacy student or not? Yes. Physiological salt solution, you have an idea? Physiological salt solution, you have an idea or not? How the physiological salt solutions were invented? The name was ringer lactate. Knowing or not? If you are Googling, Google will says. Google won't says. Okay, check it. Ringer lactate, how they are prepared. Nowadays the people are belonging to the Google, but the Google will give the 80% knowledge. The 20% of the knowledge, your expertise sitting along with you, you can get the knowledge from them, then only you will be in the 100% of the knowledge. Okay. Whatever you are given while taking, asking the question is very simple. If you are answering, that will be a difficult tool. Okay. When I was sitting, when my B.Pharm curriculum, I also used to go with these seminars and conference. The ringer lactate, how they are invented. One story was given by Dr. Gopal sir. You all know that he is the principal of Mother Teresa. Okay. He told that story when the ringer preparing the solution in his lab, he have the assistants. He will be given the formulation to every day. Then he asked the assistants to prepare the solution. After 1 hour I will come. I will mount the tissue. Whether it will give the response or not, I want to check. He was keep on preparing double distilled water, triple distilled water, whatever the many distilled water he preparing, then he is mixing, then he is always keeping, at the time not getting. He putting the many components into the water. Then the ringer will coming to the lab, giving the solution, then mounting the tissue, then getting the reading, not response. Then one day, his assistants were taken the leave. Whenever we are going in the academic profession, we used to give the alteration to someone. Whatever he is the knowledge or basic knowledge or not, we should get the alteration through someone. So, that person he altered one person, his friend. His friend was very lazy because he is working in some other department. He don't know the seriousness regarding the tissues and how he is playing, this, all those things. He came late and the ringer was asked to the person, get the water. He directly go and get the tap water and he mounted the tissue. The tissue was wondering. They are always give the response. At last he is concluded what is the tap water is containing. That only the things will be, tissue will be coming to the response. So he made that composition. Okay, that is very simple. The identification is very simple. When it will come, or accident also, the research is an accident. Many things are like that. Okay, many components are accidentally prepared. That will be whenever we are practicing. Sometimes it will be an useful, sometimes it may be a negative result. Whenever the negative results, we could not stop. We keep on following that. Then only we are able to get. Already the trial and error, whatever this product, that will be first thing. The research is very important. The trial and error method. Nowadays, everyone, we are removing the research knowledge, whatever the research is one of the art. If when I was studied in my PG, who is the good cooking person, he will be a good researcher. When you are analyzing the knowledge, okay, when you are go through the anatomy, when comparing the integral part of the mind, when compared with the male, the female will be more. Because they will be integrating all those things. Even though they are working women, morning he wants to prepare for the food and also they spend the time with the child and also they can spend with their own, then only they can. At the time the mind will be working integrally, not only in the function for the single way. So when the invention are happening, who is the good integrated person, that knowledge will be applied. Good cooker means what? One day they can add the salt or that masala is more. That cannot be a very good delicious one. Then automatically they can conclude this is the problem. They can rectify it, means the third time what they are preparing, at the time it will be a delicious one. Okay. The research also like that. That will be called as the trial and error method. Whenever we are going to start, we should know the starting. Starting in the self, whether it is at least 50% of the workload, but may not be. Nowadays, what I am saying, the cooking knowledge also, nowadays, it will be an equal. Ladies, what they are cooking, the gents also cooking in the metro city. They are sitting at home because of they are taking the lifetime. They are not going to the office, work from home. Work from home means both are in the individual rooms. They can cooking, otherwise they can Zomato or whatever the things, the research knowledge, every traditional knowledge, this will be going to then the next thing, the categories of the people, whether the young people or the child or whatever the things, accordingly we should be focused that information is needed. Okay, whatever the information given by that should be an truth and also the experience count for the particular thing. And at last, whatever he is practiced, whatever you are taking, that should be recorded properly. It's converted as an evidence. Whether you are doing the basic research or fundamental research or advanced research, whatever the research you are doing, you should be make it as an evidence. Evidence means if nowadays, if you are going for the PCA recently, wherever you are going, taking the Google Tag photos. Google Tag photo is nowadays evidence. Without the Google Tag photos, if you are submitting the photo, they cannot accept. Even all the criteria we are using nowadays behind the accreditations, all the institutes, not only the particular institute, all the institutes nowadays want the accreditation. So accreditations means simply we are loading the photos, they cannot. We need the evidence. Where you get the evidence? Evidence also in the online. You can take the Google Tag, the time and the locations, everything are there. Even though that also having some whatever the things we want to be able to edit, that technology also one side will be developing. Both will be there in that, but we don't want to take in the negative way, only we will take in the positive thing, whatever the requirement. The next thing, whenever the physician's things is over, next go with the patient side. You can assess the patient properly and also ask the questions. Questions in the sense, it should not be irritate the patient. always it should be reliable and also the comfortable. And also the whatever the colloquial language, their vernacular language, that should be more useful to get the knowledge from the patients. That is very important. You should ask proper way in the proper manner. Then the evidence, whatever the questions we are asked, whether they are replied, then followed by you are make it as an evidence, whether that should be recorded properly. Otherwise, the evidence, if you have some diagnose, if you are given, some levels are, they may think it will be reduced, but it cannot be. Then you can take it as evidence from the first day what he is having, then fifth day what he is dying, then 20th day what he is having, that whether it is decreased or increased, you make it as evidence properly, then followed by applies the evidence. Whatever the evidence you are taking, whether it is should be useful for the scientific forum, whether they are accepted or not, that conditions also we should do. Then we can apply whatever the changes they are needed, the patient needed, means we can apply and change and modify. Then self-evaluation is very important. At last, whether we are going to the performance of the particular patients, that should be truth, and also it should be make it in the proper ethics. Then assess the patients. Whenever you are assess the patients, that will be and whether the clinical problems or he is having the any other physiological problems or he is that kind of the questions you can may ask. How will you these questions may ask the questions that also having the some clinical questions derived many softwares and everything they are constructed for the case performance histories and also the clinical whatever the patients having the evidence regarding that the questions they face the patients particularly specifically regarding the disease or diagnosis you should be focused. You should not ask the randomized questions in the particular person, because if you are specific then only you can be able to identify whether if you are some doctors if you are going where is your problem, that kind of the things you should not ask. If the patient is given some particular problems, you should be specifically asked whether it is the problem in the stomach, means stomach every area the patient they are not having the knowledge, so they can ask they can say I have the stomach problem, stomach pain. You should that physician should know whether it is the abdomen or in the center or which regions are bad. This specification is very very important. Then only you properly diagnose the patients accordingly. For example, one case, this is very simple. Nowadays, 50% of the population is having the obesity along with the diabetes mellitus. Before and all, when going to the physician, the diabetes means what is the normal diabetes range? 140. Nowadays, the starting itself 300 or 350. Why? Why? Because that also in the young mind and also the adult people, whether they are having the diabetes problem. Whether I am saying statistics, okay. If you are taking the 50 to 60 people, even they are very hard worker, they are basically belongs to agriculture family. After that, if you are taking, you are checking their blood sugars. If a diabetes means we used to consider even more than 140, it is considered as a diabetes. Up to the 140 is even the range of after the 120, they are saying it is a pre-diabetics. They should be have some precautions measurements. Because of they are having the now they used to say whenever you are going to the physician, your lifestyle is changed. So we cannot change anything. But gene cannot be changed. If your lifestyle is changed, after that the gene also going to mutated. Accordingly, it should be response. That research also going. So the diabetes, it won't come directly. Okay, even though family history is there, if you have the proper knowledge and awareness regarding that, you cannot get that. Then one 65 years old man having the history of type 2 diabetes and also the obesity. He is a non-smoker and also 10 years before he had the knee surgery and also he is tried numerous diet conditions. Wherever you are going nowadays, any multi-speciality hospital you are going, after the diabetes mellitus, you can meet the dietitian. Dietitian will say you should eat in the morning this particular scale. If you eat in the evening this particular scale, you can mess up the meal. These all those things, whether working the people, it cannot be. If you stayed there in the hospital measuring the food, that will be possible. He was tried. Normal layman, if you are asking, you have the 400 diabetes, even though you are surveying for controlling the diabetes, you should take only the 1 cup of rice. The remaining, no one will be followed. Because the lifestyle will be like that. He has keep on having the particular thing. So whatever he is followed up to the age of 60, suddenly one day you want to change means it will be possible? Cannot be. Okay. If everyone thinking we can able to change the people for advising or changing or giving the knowledge, that cannot be possible. They can be, it should be practiced at least 5 to 10 years, then only it will be. Whenever you are starting the meal for your child, at the time what we are thinking, we should be give the nutrition diet to the child, then only that will be BME, will be everything will be good. Then keep on practicing after 10 years or 15 years, the child will be follow whatever the food habituation we are given. Then you can suddenly change it in the 60 years means this cannot be possible. Then the 10 years based upon his obesity, automatically he want to go with the knee replacements because then he tried numerous diet, whatever the things, and also he is not successful. Why? Then high risk for the heart disease also he know he is maintaining the diabetes. Okay. Even though he cannot lose the whatever he is expecting the weight loss, he cannot be. Then the neighbor is told the particular workout you can start, you can be able to get the thing. But even though he start with the stomach staple one technology is there nowadays, they are normal. The people wherever if you are going the modernized hospitals, various diabetes method, they can treatment method, they can include this procedure also. That method also, he wants to know this procedure really work or not. Who will be justify that thing? If he's tried all those things, whatever we are coming to know. So, these all those things cannot be worked out whenever the physiology, according to the things, the way of changing, even though the stomach stable also, it cannot be worked out. This all those things together, they wants to know or not means the answer will be, that will be, he should be know about this anatomy of the good clinical cuisines, whatever the things he wants to. Then, and also it will be helps that mnemonic, this is the one of the technology to give the compromising, focusing on the cuisines, whatever the things we want to ask, he will be given. Nowadays the pharmacy practice and also the PharmD people want to set the questions for evaluating the patient care, they can follow, then they can address to that. Then accordingly, there will be a disease outcome, whatever the promotions and advice he wants to give. Then patient problem, you should be evaluate the properly, what is the character, what is this history, what is this age, and all those things we want to focus. And also the intervention and also the progression and the factors are expressed to the particular thing, whatever the requirement for is the conditions. Then followed by the next thing, that will be an comparison. Whatever the taking the our data, you should compare with the standard, otherwise the normal thing, then only you can get the proper evidence. Then on the comparison, what is the outcome? You are practicing this thing, that thing for that many years or that many months. After the practicing also, what is the outcome? We should be conclude that. Then this is the whatever the one cases they are given, what is the outcome, these all those things for the understanding purpose. This is already what we are discussed, type 2 diabetes, that only. Then the questions through the very important, whenever we are asking the questions that should be related with the diagnosis, therapy, and also the how it is progression, it is good or bad, and also the whether it is harm. If you are go through the study regarding these evidence-based medicines, these are the meta-analysis and the systematic review, randomized control trials, and also the cohort study, case control studies, and also the case series, and also the case report, and also the animal research laboratory studies. These all the things should be supported for the thing. Then accrue the evidence. We want to conduct the whatever the research, we want to make it as evidence. That should be an efficient search should be there. Whatever before, ask the what is the source we are seeing, means whether the our colleagues are there. Even though he is an younger or elder, you should ask whatever the things we can able to implement, and followed by review of the literature, and also the review the practicing guidelines. The guidelines will be changing time to time, and also the consult the electronic databases whatever the available, and also the construct the literature search whatever the novel. Nowadays the many articles you can get, but especially the true research articles we should select. That is the separate thing. How will we select the articles? That then they are given the 4 options. First thing, that will be an whatever the things you are getting, how you can outcome based on their own experience. And the second thing, that will be an whether it is workout or the data will be very honest, and also the scientific, that will be midline whatever the given, that should be truth, and also the very ethic whatever the search we are getting, that followed by some guidelines. Without the guidelines, if you are taking the articles or reference, it cannot be work. So the guidelines, whatever the national and international guidelines they are given, you should follow. And also the for the primary care by the clinicians, as well as the prevention guidelines given by that, and also the concern about the particular research, this all the data will be given. The option 3, whatever the electronic basis system we have, you should that will be called as the statistic analysis, the tools, this all those things supporting for that. This is the literature review, how we are taking for the particular one examples I gave. Then option 4, that will be an the Medley and PubMed and elsewhere, these and all nowadays. Before, once upon a time, this will be very easily we can get it, but nowadays if you want to get that, means you should be give some paid, that support everything must be important. After get this all those things, applying the evidence is very, very important. Whether you are getting the real experience or search engines or whatever the things, you should be give the appraisal properly. Wherever you are going, they evaluate the valid data or therapy what they are done. Then what is the next step they are going to proceed, whether it will be an basic things are given directly. Whenever we are going to the analyzing the data, it should not be in the direct answer. That will be a step-by-step procedure is very important from the basic level. From the basic level questions and also the basic level evidence, followed by the next stage, that will be methodological evidence, then outcome based evidence. These all those things you should be properly appraised, then only you can get the particular whatever the outcome, what you are expecting outcome, you may able to get. So all these things I am concluding my session. If you have any doubts, you can. Okay. Thank you sir once again. Once again I thank you our chairperson Balan sir and Manogaran sir, and also the principal for the Shanmugha Group of Institution giving this opportunity to me. Thank you.
Thank you, Sengotivel sir. Very nice explanation. Very simply given so many informations. How many people you are understood now? What is evidence-based medicine? Anyone can able to tell? Only one basic concept information anyone can tell? Then I will give you 500 rupees for you. You can tell your own language, no problem. Tamil, you can use it. But student has to tell. தெரியுமாப்பா யாராவது சொல்ல முடியுமா ப்ளீஸ் கம் ஒரு மைக் கொடுத்துருங்க எவிடன்ஸ் பேஸ்ட் மெடிசன் வந்துக்கலாமா வாங்க இவ்வளவு பெரிய செஷன்ல ஒரு பொண்ணு எழுந்திருச்சிருக்காங்க அதுவே ஒரு பெரிய விஷயம் ஃபர்ஸ்ட் கிளாப் பண்ணுங்க 4வது பெஞ்சில் உட்கார்ந்தே தூங்குறவங்க இருக்காங்க 25வது லைன்ல இருந்து ஒரு பொண்ணு வந்திருக்காங்க ரொம்ப சந்தோஷம் வாங்க பேர் சொல்லிட்டு உங்க பேர் உங்க காலேஜ் இன்ட்ரோ듀ce பண்ணிக்கிட்டு நீங்க ஆன்சர் சொல்லிடலாம்
So good morning, sir. I'm Pooja from Pharmacological College of Pharmacy and Research. So basically, evidence-based medicine is an approach to a clinical decision making using the patient research data and other available evidence for better decision making in clinical science.
Thank you. 500 rupees வேணுமா
பரவாயில்ல
இங்க வா
Welcome to all for choosing this Shanmugha College of Pharmacy. நாங்க வந்து we are giving some encouragement like not other, like other colleges. When you are studying you can earn the money monthly 10,000 15,000, not like that. Okay. Depends on knowledge. You also can earn the money for encouragement. You can give a big applause to her. It's what's your name? Yes, Pooja. She came forward. Which college? Pharmacological College of Pharmacy. For given the answer, we have to give some contribution to her. Congratulations, Pooja, from Pharmacological College of Pharmacy. It's a cash prize.
Thank you, pa. Thank you. கேட்போம் கண்டிப்பா கொஸ்டின் கேட்போம் இப்ப கோவிட்னு ஒரு புதிய நோய் வந்துச்சு அதுக்கு மெடிசன் இல்ல அப்ப நம்ம என்ன செஞ்சாங்க டாக்டர்ஸ் எல்லாம் ஒரு பெரிய மீட்டிங் போட்டு ஒரு என்னென்ன கூறுகள் கவனிச்சிருப்பாங்க பேசிக்கா நம்மளோட என்னென்ன ப்ராப்ளம் கோவிடுக்கு இருக்குது அப்படின்னு சொல்லி ஃபர்ஸ்ட் ஒரு ஷார்ட் லிஸ்ட் பண்ணிருப்பாங்க என்னென்ன ப்ராப்ளம் வருதுங்க, இந்தந்த ப்ராப்ளத்துக்குலாம் தனித்தனியா என்னென்ன மெடிசன்ஸ் இருக்குது அப்படிங்கறத ஒரு ஷார்ட் லிஸ்ட் பண்ணிருப்பாங்க. அது முடிஞ்ச பிறகு ஒருத்தருக்கு ஃபர்ஸ்ட் ட்ரீட்மெண்ட் கொடுத்துருப்பாங்க. அவங்களுக்கு அந்த ஃபீட்பேக்க வாங்கியிருப்பாங்க. ஃபர்ஸ்ட் ஒரு 2 மெடிசன் கொடுத்து பார்க்கும்போது சார் எனக்கு வாமிட்டிங் சென்சேஷன் அதிகமா இருக்குது அப்படின்னு சொல்லியிருப்பாங்க இல்லையா. அப்ப நான் என்ன பண்ணிருக்கோம், உடனே அடுத்த பேஷண்ட்ஸ் கூட ஒரு ஓரன்செபன் டேப்லெட் சேர்த்து கொடு. Psychologically already they are affected, so the anti-emetic with the psychotical depressant olanzapine drug they will add it and they given. After 1 week the same patient came 2 or 3 days. Then they told, yes sir, we are not getting any vomiting. I am calmly, I am sit. So it's for me better. We are taking the feedback from the patient. Understand? Then next, some people they are died within 7 days. Some people they are survivable 14 days after that they died. Some people they are better. What are the medicines we given? That all the things they accepted, the medicine 100%, then they are survival extended. So, based upon all the criteria, the government of Tamil Nadu itself, they given one list of drugs can be prescribed. You know, in that first drug is azithromycin 500. You know, you are all pharmacy people know, azithromycin 500, have you here? Azithromycin 500 is antibiotic, they have started. Understand? Then after that in addedly, they are given for this hydroxychloroquine, that also is prescribed in Tamil Nadu government. Then next, they are added for some zinc tablet for, so to improve this immune system purpose, zinc they are added. Then after that they are added for some anti-emetic drugs for the side effects removing purpose. Then some people, sir, we cannot able to, heart rate is increasing, we cannot able to tolerate. People, so they are added for some anti-coagulant tablet also to prevent the coagulations. Understand? See, all the things by trial and error method, so many people they are died, but they learned from that and they prescribed, and after that they given one template of these are all the medicines we can give for 5 days, one set of medicine 5 days. If it does not work, this then second set of medicines they given, and third set of medicines also they prepared and they kept. This is the best example for evidence-based medicine. Okay, so it is a new approach. We don't know this, we don't know the drug, which medicine we have to give, but we know the drug knowledge one side, we know the patient order informations one side. Based upon these two, with the judgment, we are judging this. Yes, this is the best we can try. This all these we are mixed and we are getting this evidence-based medicine. That is the success of our COVID. We came out very quickly, but many people they died. But so many people we saved also. Understand? So this is the best medicine. This is the best approach we applied. This approach is called evidence-based medicine approach. Okay, have you understood? Have you understood now? Sure? Have you understood now? Okay. Then second question. I have The next question is, what is the basic approaches or involve this evidence-based medicine? What are the steps we have to be? Sir is given so many steps sir, these are all the steps we can go for, we can get it better. That anyone can able to tell 3 steps, 3 things. அது யாரு இன்னொரு ஆள் கை தூக்குறாள் சேம் பர்சனுக்கு இல்ல இன்னொருத்தருக்கு ஆப்பர்ச்சுனிட்டி கொடுக்கலாம் அவங்க சொல்லலைன்னா உங்களுக்கு ஆப்பர்ச்சுனிட்டி ஆன்சர் கொடுங்க சரியா தேங்க்யூமா சொல்லு வேற யாராவது சொல்ல முடியுமா என்னென்ன கிரைட்டீரியா என்னென்ன ஃபேக்டர் என்னென்ன ப்ரொசீஜர்ஸ் நம்ம இன்வால்வ் பண்ணா இந்த பெஸ்ட் எவிடன்ஸ் பேஸ்ட் மெடிசனை நம்மளால எடுத்துட்டு வர முடியும் தமிழ்ல சொல்லலாம்ப்பா ஒன்றும் தப்பு இல்லை தெரியலையா அந்த பொண்ணு சொல்ல இன்னொரு ஆள் இருக்கு வாங்க பாவை காலேஜா ஆன்சர் பாஸ் பண்ணிட்டாங்க போல இதோட எய்ம் என்ன தெரியுமா நீ முன்னாடி உட்காந்து தூங்க கூடாதுன்னு அர்த்தம் என்ன பண்ணும் இதோட எய்ம் என்ன முன்னாடி உட்காந்து தூங்க கூடாது பாரு நல்லா உட்காந்தா 500 ரூபாய் வாங்கிருக்கலாம் பாப்பா
Good morning, sir.
Come, friend. Here, come, then speak.
Good morning, sir. I'm Harita from Pharmacy College of Research. Steps: access the patient. First step: access the patient. Second step: ask question. Third step: acquire evidence. Fourth step: appraise the evidence.
ரெண்டு விட்டுட்டேன் ரெண்டு தான் கேட்டேன் அதனால தானே All you get right.
Access the first step: access the patient. Second step: access ask question. Third: acquire evidence. Fourth: appraise the evidence. Sixth: self evidence. Apply. Talk with patients. That's all.
Thank you. ஒரு 90% பொண்ணு கவர் பண்ணிடுச்சு வெரி குட் தேங்க்யூ மா தேங்க்யூ தேங்க்யூ ஸோ மச் இல்லைங்க காசு வேணாமா வேணான்னா போலாம் நான் வாங்கி பாக்கெட் வச்சுப்பா லைக்
Harita from Pharmacology College of Research.
Harita from Pharmacological College. இவ்வளவு பெரிய ஸ்கிரீன்ல நம்ம முகத்தை காமிக்கிறது எவ்வளவு பெரிய விஷயம் இங்க வந்தவங்க எவ்வளவு பேர் உட்கார்ந்துருக்கீங்க 2 பேர் தான் இங்க வந்து முகத்தை காமிச்சிருக்கிறாங்க இவ்வளவு பெரிய ஸ்கிரீன்ல நம்ம முகம் தெரிஞ்சிச்சு அந்த 2 பேருக்கு தான் அடுத்த செஷன்ல இருந்து உங்க முகமும் தெரியணும்னு வச்சுக்கோங்க நீங்க என்ன பண்ணணும் லிட்டில் கியூரியஸோட அவங்க என்னதான் சொல்றாங்க நம்ம கொஞ்சம் கேட்டு பார்க்கலாம் சரியா கொஞ்சம் முடிஞ்ச அளவுக்கு அதை ஞாபகப்படுத்துவதை எழுதி வைக்கலாம் இது 2 நம்ம செஞ்சோம்னா கண்டிப்பா அடுத்த செஷன்ல கேட்கிற கொஸ்டினுக்கு நீங்க வாங்கிடலாம் சரியா ஓகேவா ப்ளீஸ் with open-mindedly attend the session all the things you will get it well okay thank you so much
I thank Dr. Balan sir and S.S. Sandhu Kumar sir for your active participation. It's my pleasure to call upon our esteemed chairpersons to honor our chief guest, Dr. T. Sengottawil.
I don't want to talk much because the evaluator has to talk less than the speaker. So he talked more. So evidence-based medicine, the evidence should not be the positive one. And that only I am saying. Sometimes negative evidence also needed for this evidence-based medicine. One thing I want to give the example, paracetamol induced hyperthermia. Do you know that? Paracetamol induced hyperthermia. Paracetamol எது குடிக்கிறோம் ஹைப்போதெர்மியா குடிக்கிறோம் Or evidence review, paracetamol itself can induce the hyperthermia. Another one evidence is antiemetic induced emesis. This is also one of the evidence. These are the rare evidence we have. So some people are told that evidence is important. Other than that, the important one is the skill of the practitioner and the interpretation of the evidence will be varied. Even evidence tool are saying, if you are taking the MRI scan, if you give it to doctors, they will give a different opinion. The evidence is same, but by the experience they are saying, one is saying that you need to go for the surgery, but another one is saying no. By the experience they are saying. So evidence based, not necessary that all the way it should be the positive, sometimes it will be the negative also. This is the two important example. You can go and search in that net. This is the rare evidence. Paracetamol induced hyperthermia and antiemetic induced emesis. This is another one additional information for you. So for all, you can take it. And the important one is so-called post-marketing survey. That is very, very important one. All the companies, they are avoiding before getting the post-marketing survey result. They released the drug. They got evidence also. Even if you are taking the nimesulide, one example I will take, this is the non-steroidal anti-inflammatory drug. Previously, we used the language is banned. The origin of the nimesulide is from US. The US company only made that one. They released the FDA gave the approval for that one. They released that also. In the post-marketing survey, they found that it is the reason for the gastric leakage, means gastric bleeding will comes for the nimesulide while we are taking with the ulcerous patient. They withdrawn that. So while this is giving drug crossed 4 clinical trials, even FDA also given the approval for that, then how we are getting the negative result from the population, that is the group of the population. When we are going for the clinical trials, maximum we are taking the 1,000 patient only we are taking. In the post-marketing survey, the population is more, that's why the value also significant. Instead of giving the 1,000, if you are giving the lakhs, about the lakhs, somebody will give the negative also. The post-marketing survey is the fiercest one for the companies for getting the success of the drug, not for getting the approval from the FDA. FDA approval வாங்குறது ஒரு பெரிய விஷயம் இல்ல. கிளினிக்கல் ட்ரையல்ஸ் முடிச்சு அவங்க approval கொடுத்துருவாங்க. மார்க்கெட்டுக்கு அந்த ட்ரக் போன வரைதான் நிறைய கம்ப்ளைண்ட்ஸ் வரும். இந்த ஃபார்மகோ விஜிலன்ஸ் ஒன்று கேள்விப்பட்டிருப்பீங்க. ஏகப்பட்ட கம்ப்ளைண்ட் வரும். ஃபர்ஸ்ட் யூஎஸ் அதை பேன் பண்ணாங்க. திரும்பியும் அந்த ட்ரக் வந்து யூகேக்கு போச்சு. 10 வருஷம் FDA வந்து அப்ரூவல் கொடுத்து யூஎஸ் பேன் பண்ணதுக்கு அப்புறமும் 10 வருஷம் இந்தியாவில நம்ம நிமிஷம் யூஸ் பண்ணலாம். இது உங்களுக்கு ஒரு இன்ஃபர்மேஷன் கொடுத்தல. We know that. அவங்க பேன் பண்ணிட்டாங்கன்னு தெரியும். 10 வருஷம் அந்த நான் ஸ்டீராய்டல் இன்ஃப்ளமேட்டரி நம்ம யூஸ் பண்ணிட்டு தான் இருந்தோம். அதுக்கப்புறம் அதை பேன் பண்ணிட்டாங்க. இந்தியாவை பேன் பண்ணி வச்சு இது ஒரு இம்பார்ட்டன்ட் எக்ஸாம்பிள் ஃபார் தி போஸ்ட் மார்க்கெட்டிங் சர்வே. Okay, right? Thank you very much.
Thank you, sir. It's my pleasure to call upon our esteemed chairpersons to honor our chief guest, Dr. T. Sengutavil. Like to call upon stage Dr. P. Suresh Kumar, Principal, and Dr. P. Perumal, Vice Principal, Sri Shanmugha College of Pharmacy, to honor our esteemed chairperson, Dr. P. Balan. I would like to call upon stage Dr. C. Senthil Kumar, Head of the Department Pharmaceutics, to honor our esteemed chairperson, Dr. S. Manoharan. Thank you everyone. I kindly ask all the e-poster presentation participants to proceed to Seminar Hall A block for your presentation. Now I ask all the delegates and students to take a tea break and assemble back in 15 minutes for the oral presentation. First of all, I would like to call Jai Karthi from Shanmugha College of Pharmacy to present his presentation.
Good morning to one and all. My name is T. Jai Karthi. I am coming from Shanmugha College of Pharmacy. Today, I want to represent my presentation as formulation and evaluation of novel lozenges for dual therapeutic targets for the management of hypertension and hyperlipidemics. Let me explain what is hypertension. Hypertension is a condition in which elevated blood pressure and hyperlipidemic is defined as the increase in blood cholesterol level. My introduction was lozenges are the flavored. It is அது வந்து ஒரு flavored medical dosage form. இது ஒரு solid dosage form. இதை வந்து நம்ம வந்து எப்படி அட்மினிஸ்ட்ரேஷன் பண்றோம் அப்படின்னா route of administration mouth or pharynxல பண்றோம். இதுல வந்து என்னன்னா 2 or more medicaments வந்து நம்ம என்னன்னா இன்சிஸ்ட் பண்ணி நம்ம வந்து இதுல லொசஞ்சஸ் எடுத்துக்கும் போது அத ட்ரக்ஸ் வந்து கான்ஸ்டன்டா நம்ம வந்து அந்த ட்ரக்ஸ் வந்து நம்ம ஸ்லோவா ரிலீஸ் ஆகும். இது வந்து என்னன்னா ஒரு பாப்புலர் அண்ட் இன்னோவேட்டிவ் டோசேஜ் ஃபார்ம் அண்ட் இது வந்து என்ன அப்படின்னா ஈஸியாவும் அட்மினிஸ்ட்ரேஷன் பண்ணலாம். நெக்ஸ்ட் இதோட எஃபெக்ட்ஸ் வந்து லோக்கலி அண்ட் சிஸ்டமேட்டிக்லி இருக்கும். இது எதுக்காக நான் எடுத்தேன் அப்படின்னா ஜீரியாட்ரிக் அண்ட் பீடியாட்ரிக் பேஷண்ட்டுக்கு கொடுக்கறதுக்காக எடுத்திருக்கேன். இதுல வந்து என்ன அப்படின்னா நான் என்ன கொடுத்திருக்கேன் அப்படின்னா நியூ ட்ரக் டெலிவரி சிஸ்டம் மூலியமா என்னத்துக்காக எடுத்திருக்கேன் அப்படின்னா எஃபிகேசி இன்க்ரீஸ் பண்றதுக்காகவும் ஃபர்ஸ்ட் பாஸ் மெட்டபாலிசம் அவாய்ட் பண்ணிட்டு நெக்ஸ்ட் வாட்டர் இன்டேக் இல்லாம இதை வந்து பண்றதுக்காக எடுத்திருக்கேன். நெக்ஸ்ட் லொசேஜஸோட அட்வான்டேஜஸ் அண்ட் டிஸ்அட்வான்டேஜஸ் என்ன அப்படின்னா இது வந்து என்னன்னா பீடியாட்ரிக் அண்ட் ஜீரியாட்ரிக் பேஷண்ட்ஸ் எடுத்துக்கலாம். இதுல வந்து என்னன்னா பிளசன்ட் டேஸ்ட் இருக்கும். நெக்ஸ்ட் இதுல வந்து நம்ம ஸ்வீட்னஸ் அண்ட் பிளேவர்ஸ் நம்மளுக்கு ஏத்த மாதிரி நம்ம வந்து என்ன பண்ணலாம் அப்படின்னா மாத்திக்கலாம். இது நம்ம ப்ரிப்பேர் பண்றதுக்கு மினிமம் எக்யூப்மெண்ட்ஸ் இருந்தாவே போதும். நெக்ஸ்ட் இதோட சிஸ்டமேட்டிக் அப்சர்வேஷன் வந்து என்னன்னா ஈஸியாவே பக்கல் கேவிட்டிலே நடக்குது. அதனால இதெல்லாம் வந்து லொசஞ்சஸோட அட்வான்டேஜஸ். இதோட டிஸ்அட்வான்டேஜ் என்ன அப்படின்னா இது வந்து என்னன்னா நம்மளோட வீட்டுல சாதாரணமா இருக்க குழந்தைகள் வந்து மிஸ்டேக்கனா கேண்டி மாதிரி இருக்கனால இது மிஸ்டேக்கனா எடுத்துக்கலாம். நெக்ஸ்ட் வந்து என்னன்னா ஹீட் ஸ்டேபிள் வந்து சூட்டபிளா இருக்கும். இதுல வந்து என்னன்னா சம் ஆல்டிஹைட் கேண்டி பேசஸ் எக்ஸாம்பிள் பென்சோகேன் யூஸ் பண்ண முடியாது. இதுல வந்து என்னன்னா மினிமம் பிட்டர் டேஸ்ட் இருக்கிறது மட்டும் சூட்டபிள். நெக்ஸ்ட் ஃபர்ஸ்ட் லொசஞ்சஸ் வந்து என்னன்னா வேரியஸ் ஷேப்ல இருக்கும். இது ஒரு சாலிட் டோசேஜ் ஃபார்ம். நான் முன்னாடியே சொன்ன மாதிரி இதுல வந்து என்னென்ன டைப்ஸ் இருக்கு அப்படின்னா ஹார்ட் கேண்டி லொசஞ்சஸ், சாஃப்ட் கேண்டி லொசஞ்சஸ் அண்ட் சியூவபிள் லொசஞ்சஸ்னு இருக்கு. இதுல நான் எடுத்துக்க போறது என்ன அப்படின்னா ஃபர்ஸ்ட் கிரீன் டீ வந்து என்னன்னா இது எதுல இருந்து எடுத்துக்கிறோம்னா கேம்லஸ் சைனஸ்ன்ற ஒரு இதுல இருந்து எடுத்துக்கிறோம். இது ஒரு ஓல்டஸ்ட் ட்ரிங்க். இதுல வந்து நிறைய பயோஆக்டிவ் காம்பவுண்ட்ஸ் இருக்கு. இதுல வந்து நார்மலாவே நம்ம கிரீன் டீ எடுத்துக்கிறதுக்கு எதுக்கு எடுத்துக்கிறோம்னா ஒபிசிட்டி, நிறைய கார்டியோவாஸ்குலர் சிஸ்டம் சம்பந்தமான நோய்கள் வராம தடுக்கிறதுக்காக நிறைய யூசஸ் வந்து கிரீன் டீல இருக்கு. இதுல நான் என்ன கொண்டு வரேன் அப்படின்னா லிபிட் லெவல்ஸ் இது பண்றதுக்காக லொசஞ்சஸ் மூலியமா பண்றதுக்காக இது கொண்டு வந்திருக்கேன். நெக்ஸ்ட் இன்னொரு கண்டென்ட் என்னன்னா ஆம்லங்கிறதுக்கு இன்னொரு நேம் வந்து இந்தியன் கூஸ்பெரி. இதோட சயின்டிபிக் நேம் வந்து ஃபைலாந்தஸ் எம்பிலிகா லினேசியஸ். இது ஒரு ஆயுர்வேதிக் சிஸ்டம். இதுல வந்து என்னன்னா விட்டமின் சி ரிச்சா இருக்கு. இது வந்து ஜென்ரலாவே பிளட் கொலஸ்ட்ரால் லெவல் கம்மி பண்ணுது அண்ட் பிளட் வெசல்ஸை வைட் பண்ணுது. இதுல நம்ம ரெகுலரா மார்னிங்ல என்ன ஆம்லா ஜூஸ் எடுத்துக்கும் போது நம்மளோட ஹைப்பர் டென்ஷன் கம்மியாகும். இதுதான் வந்து இதை எடுத்துக்கிட்டதுக்கான காரணம். நெக்ஸ்ட் வந்து நான் என்ன ட்ரக், அதாவது நான் இதுல கொடுக்க போற ட்ரக்ஸ் என்ன அப்படின்னா, ஒன்னு அஸ்ட்ரோவேட்டின், இன்னொன்னு வந்து அம்லோடிபின். அஸ்ட்ரோவேட்டின்ங்கிறது வந்து என்ன அப்படின்னா, இட்ஸ் ஹெச்எம்ஜி கோயே ரிடக்சேஸ் இன்குபிட்டர். அது வந்து நெக்ஸ்ட் அம்லோடிபின், இது கால்சியம் சேனல் பிளாக்கர்ஸ். நெக்ஸ்ட் இந்த லொசஞ்சஸ் எப்படி ப்ரிப்பேர் பண்றேன் அப்படின்னா, ஃபர்ஸ்ட் எவாலுவேஷன் டெஸ்ட், அதுக்கப்புறம் என்னென்ன ட்ரக்ஸ் நான் வேணுங்கிறத கலெக்ட் பண்ணிட்டு அது இது பண்ணும். நான் இதுல வந்து ஃபார்முலேட் பண்றது 3 டைப் ஆஃப் இது பண்ணலாம். ஹெர்பல் லொசஞ்சஸ், சிந்தட்டிக் ட்ரக் லொசஞ்சஸ், ஹெர்பல் அண்ட் ட்ரக் லொசஞ்சஸ் அப்படின்னு பண்ணலாம். நெக்ஸ்ட் இதுல நான் என்னென்ன பிளான்ஸ் பண்றேன் அப்படின்னா, ஃபர்ஸ்ட் லிட்டரேச்சர்ஸ் கலெக்ட் பண்ணிட்டு, அதுக்கப்புறம் வந்து என்னன்னா ஹெர்பல் எக்ஸ்ட்ராக்ட வந்து கலெக்ட் பண்ணிட்டு, ஆம்லா ஜூஸ், கிரீன் டீ எக்ஸ்ட்ராக்ட், அதுக்கப்புறம் வந்து என்னன்னா ஃபார்முலேட் பண்றது மெத்தட், அதுக்கப்புறம் என்ன நான் பண்றேன் சிந்தட்டிக் ட்ரக், அதுக்கப்புறம் ஹெர்பல் எக்ஸ்ட்ராக்ட்ஸ் மூலியமா நான் பண்றேன், அதை நான் ரெப்ரசென்ட் பண்ணேன். நெக்ஸ்ட் இதுல நான் என்ன டெஸ்ட் எல்லாம் பண்ணிருக்கேன் அப்படின்னா, ஹார்ட்னஸ் டெஸ்ட், ஃப்ரையபிலிட்டி டெஸ்ட், டிஸ்இன்டிகிரேஷன் டெஸ்ட், டிசொல்யூஷன் டெஸ்ட், மாய்ஸ்சர் அனலைசிஸ், மைக்ரோபியல் எக்ஸாமினேஷன், இது எல்லாமே நான் பண்ணிருக்கேன். இதுல நெக்ஸ்ட் இதுல யூஸ் பண்ண மெட்டீரியல்ஸ் வந்து என்னென்ன அப்பாரட்டஸ் யூஸ் பண்ணிருக்கேன் அப்படின்னா, ஃபைப்ரேட்டர், ஃபிசர், ஹார்ட்னஸ் டெஸ்டர், டிசொல்யூஷன் அப்பாரட்டஸ், டிஸ்இன்டிகிரேஷன் அப்பாரட்டஸ் நான் யூஸ் பண்ணிருக்கேன். இந்த நெக்ஸ்ட் பிளான்ட் வந்து எங்க இருந்து நான் கலெக்ட் பண்ணிக்கிட்டேன்னா, முன்னாடி சொன்ன மாதிரி பைலாந்தஸ் எம்பிலிகா அதுல இருந்து ஃப்ரூட்ஸ் நான் கலெக்ட் பண்ணிக்கிட்டேன். நெக்ஸ்ட் டீ லீவ்ஸ் வந்து எதுல இருந்து கலெக்ட் பண்ணிக்கிட்டேன்னா, கேமிலா சைனஸ்ல இருந்து கலெக்ட் பண்ணிக்கிட்டேன். நெக்ஸ்ட் இதுல எக்ஸ்ட்ராக்ட் நான் எப்படி பண்ணேன் அப்படின்னா, ஆம்லா ஜூஸோட எக்ஸ்ட்ராக்ட் எடுத்துக்கிட்டேன், அதை வாஷ் பண்ணிட்டு, அதை கிளீன் பண்ணிட்டு, அதை ஸ்மால் பீஸ் பண்ணிட்டு, பல்ப் பண்ணிட்டு ஃபில்ட்ரேட் பண்ணிக்கிட்டேன். நெக்ஸ்ட் கிரீன் டீ எக்ஸ்ட்ராக்ட், அதோட லீவ்ஸை வந்து கலெக்ட் பண்ணிட்டு, அதை வந்து என்ன பண்ணேன்னா வாட்டர்ல போட்டு அதை நான் ஹீட் பண்ணி அதோட எக்ஸ்ட்ராக்ட் எடுத்துக்கிட்டேன். ஜென்ரலா நம்ம ப்ரிப்பேர் பண்ற லொசஞ்சரோட ப்ரொசீஜர் என்ன அப்படின்னா, சுகர் சிரப்பை எடுத்துக்கிறோம். நெக்ஸ்ட் வந்து என்னன்னா டெக்ஸ்ட்ரோஸ் வாட்டரா மிக்ஸ் பண்ணி அதை வந்து என்ன பண்றோம்னா அதோட இதை எடுத்துக்கிறோம். நெக்ஸ்ட் நம்மளுக்கு தேவையான ட்ரக் ப்ராடக்ட்ஸ் வந்து என்ன பண்றோம் அப்படின்னா, அதை ரெண்டுத்துலயும் மிக்ஸ் பண்ணிட்டு நம்ம வந்து என்னன்னா அது ஒரு அலுமினியம் ஃபாயில்ல ஹோல்ட் பண்ணி ப்ரிசர்வ் பண்ணி மாய்ஸ்சர் இல்லாம வச்சுக்கலாம். நெக்ஸ்ட் எப்படி ஒரு ட்ரக்கையும் ஒரு ஹெர்பல் ப்ரொசீஜர்ஸையும் நான் இது பண்ணேன் அப்படின்னா, குவான்டிட்டிஸ் சுகர் சொல்யூஷன் எடுத்துக்கிட்டேன், அதுக்கப்புறம் வந்து என்னன்னா டெக்ஸ்ட்ரோஸ் சுகர் எடுத்துக்கிட்டேன், அதுக்கப்புறம் வந்து என்னன்னா ஃபார் அம்லோடிபின் லொசஞ்சஸ் ஐ டுக் அ ட்ரக் அம்லோடிபின் அண்ட் வித் ஆம்லா ஜூஸ். அதுக்கப்புறம் வந்து அதுக்கு ஃபிளேவர் கொடுத்தேன், அதுக்கு வந்து என்ன ஷேப் வேணுமோ அதை நான் இது பண்ணிட்டு பாலித்தீன் ரேப்ல இது பண்ணிட்டேன். நெக்ஸ்ட் ஹெர்பல் ப்ரொசீஜர்ஸ்க்கு அதே ப்ரொசீஜர், ஆம்லா ஜூஸோட இது பண்ணிட்டு அதை வந்து நான் வேப் பண்ணிட்டேன். நெக்ஸ்ட் இதுல என்னென்ன எவாலுவேஷன் பேராமீட்டர்ஸ் கொண்டு வந்தேன்னா, முன்னாடி சொன்ன மாதிரி ஃபைபிலிட்டி டெஸ்ட், ஹார்ட்னஸ் டெஸ்ட், இன்விட்ரோ மவுத் டிசால்விங் டைம், ட்ரக் கண்டென்ட் மாய்ஸ்சர் கண்டென்ட் அனாலிசிஸ், ஸ்டெபிலிட்டி ஸ்டடிஸ், டிசொல்யூஷன் டெஸ்ட், டிஸ்இன்டிகிரேஷன் டெஸ்ட், இது எல்லாமே நான் பண்ணியிருக்கேன். நெக்ஸ்ட் இதுல நான் என்னென்ன பாராமீட்டர்ஸ் கொண்டு வந்திருக்கேன்னா, அதோட ஷேப், இது மூலியமா நான் கொண்டு வந்த லொசன்சஸோட ஷேப் வந்து ஸ்பெரிக்கல், கலர் வந்து பிரவுன் அண்ட் கிரீன் கொடுத்தேன். நெக்ஸ்ட் டெக்ஸ்சர் வந்து ஸ்மூத், அதுக்கப்புறம் டேஸ்ட் வந்து ஸ்வீட். இது என்னோட பிசிக்கல் பாராமீட்டர்ஸ் நாங்க கொடுத்தது, இது பண்ணிட்டு இருக்கேன் நான் எடுத்தது இந்த பிசிக்கல் பாராமீட்டர்ஸ் லொசன்சஸ்க்காக. நெக்ஸ்ட் இதுல வந்து என்னன்னா கிரீன் டீ லொசஞ்சஸ், அதுக்கப்புறம் வந்து மேல இருக்கிறது வந்து கிரீன் டீ லொசஞ்சஸ், அது வந்து ஹெர்பல் லொசஞ்சஸ், கீழே வந்து ஹெர்பலையும் ட்ரகையும் மிக்ஸ் பண்ணி ஒரு லொசஞ்சஸ், ஆஸ்ட்ரோவேட்டின் அண்ட் கிரீன் டீ லொசஞ்சஸ். இது வந்து என்ன அப்படின்னா ஹைப்பர் லிபிடிக் லொசஞ்சஸ் யூஸ் பண்ணலாம். நெக்ஸ்ட் வந்து என்னன்னா அமலா லொசஞ்சஸ் வந்து என்னன்னா ஜென்ரலா கொடுக்கலாம். அடுத்தது வந்து அம்லோடிபின் ட்ரக், அதுக்கப்புறம் ஆம்லா லொசஞ்சஸ் கொடுத்துருக்கேன். இதுல வந்து என்ன நான் கன்க்ளூட் பண்றேன் அப்படின்னா, லொசஞ்சஸ் வந்து என்னன்னா இது பண்ணிக்கலாம். இதுல வந்து ஓடிசிக்கு இது வரலும் ட்ரக்ஸ் இருக்கு, இது மூலியமா நம்ம வந்து பீடியாட்ரிக் பேஷண்ட்ஸ்க்கு யூஸ்ஃபுல்லா இருக்கும் அப்படின்றது என்னோட கன்க்ளூஷன்.
Kind note please. A block F4 voice common difference in the I kindly repeat, two of prayer command voice A block F4 voice common difference.
You go to first slide, title, formulation and evaluation. Remove some of the material snapping and unloading.
Sir, for it is not a proven for நாங்க வந்து இந்த சயின்டிபிக் இன்னும் இது
Do you have any evidence that this food drug will be absorbed with buccal? Buccal absorption how இது evidence வச்சிருக்கியா? இது oral formulation தான் டேப்லெட்டா இருக்கிறோம். ஒரு கேண்டியா பண்ணனா அட்டோரியாஸ்டாட்டினோ அமினோடிபினோ அப்சார்ப் ஆகும் அப்படிங்கிறது எவிடன்ஸ் இருக்கா?
சரி இதை நான் ப்ரூஃப் பண்ணிட்டேன். இது பிசிக்கல் பாராமீட்டர்ஸ் வச்சு
செலக்ட் பண்றதுக்கு முன்னாடி நீ பார்த்துருக்கணும்ல. ஒரு மிட்டாயை போடுறாங்கன்னா அது வாயிலே அப்சர்வ் ஆகும். அதுக்கான எவிடன்ஸ் இருக்கா?
நீங்க எடுத்துக்கிறது அந்த கேண்டிக்கான எவாலுவேஷன் பண்ணியிருக்கீங்க.
But you don't have any evidence that this food drug will be absorbed buccally. Absorb பண்ணாதான் நமக்கு எஃபெக்ட் வரும். அதுக்கு எவிடன்ஸ் வேணும். இல்ல வச்சிருக்கீங்களா?
Thank you, Bob. First, very speaking. Thanks. The oral presentation is mainly we have to present it in only in English, not in Tamil. So try to speak in English completely. Then only it's good. Okay. Thank you.
Thank you, Jay Gandhi. Now moving on to the next presenter, P. Sindhura Pandi from Sri Shanmugha College of Pharmacy.
Good morning to one and all present here. Myself, Sindhura Pandi. I am currently pursuing Shanmugha College of Pharmacy. Retrospective study on survival analysis of breast cancer patient receiving hormonal and non-hormonal therapy. Introduction. Breast cancer is a disease in which cells in the breast go out of control. The breast cell mutate and become cancer cells and multiple in number to form tumors. Breast cancer is common type of cancer affected by women. Next. Like multiple type of breast cancer that include luminal A. Luminal A, there are three kinds of receptor: estrogen, estrogen, HER2 receptor. HER2 human epidermal growth factor receptor 2. First, luminal A, there is estrogen positive, progesterone positive, HER2 only negative. Luminal B, estrogen positive, progesterone negative, HER2 negative. Luminal C, estrogen positive, progesterone negative, HER2 positive. HER2 non-expression, estrogen negative, progesterone negative, HER2 positive. Triple negative means three receptor negative type. There is no metastasis. This is spread to various parts of the organ. The screening methods of breast cancer, such self-examination, that's mammogram. Mammogram is nothing but X-ray image. Next, MRI scan, USG report, biopsy technique. Biopsy technique is important. Biopsy means removal of particular tissue in affected part. The treatment for breast cancer. Surgery MRM modified radioactivity. The cancer growing large number, but actually that part is removed. Then chemotherapy. There is satellite fat cycle, fluoroscopy. Then radiotherapy, EPR2. With external beam radiation therapy, plus hyperthermia. That's all. The aim is to study survival analysis of breast cancer, patient receiving hormonal and non-hormonal therapy. Objective is to find the patient with breast cancer receiving hormonal and non-hormonal therapy to compare the survival rates of hormonal and non-hormonal therapy receiving cancer patients. I come to only there is hormonal and non-hormonal therapy, which one has greater survival rate. Next one. This is methodology. Retrospective data of cancer patient was collected in Then 5 years data of 501 breast cancer patients were tracked in Tecoma 5,000 records and stored in Excel sheet. Then patient data was analyzed using Prism Pack and SPX 18.0 software. Survey rate is analyzed using Captain Layer curve. Next slide. Result is age-based calculation persons, number of persons find on the data collected, then most of the persons collected is most non-person persons, 50 to 59 age, 30.0, 10%. This result, next monoperson status is classification, 195%, non-person persons have higher rate of breast cancer, 64%. The age between 44 to 45. Next, prevalence wise classification. Prevalence wise classification, null person means the person who cannot giving to pregnancy, but the higher rate of breast cancer person Africa is 47.90. Next one. As IHP diagnosis. IHP means immunohistochemistry. Immunohistochemistry test. The higher report is about progesterone positive, estrogen positive, and factor receptor negative, 50.80%. Next slide. Next, receptor is classification. Estrogen receptor negative result is high, and progesterone receptor 57.50 and hetero receptor, female epidermal growth factor receptor 2, negative result is high. Next. The classification based on receiving hormonal therapy. Hormonal therapy received patients 36.3%, non-hormonal therapy 63.7%. Next slide. Next, this is hormonal therapy received patients. Next slide, letrozole. Letrozole has higher rate in breast cancer, 60.40%. Next slide. The survival of persons based on hormonal therapy. Hormonal therapy, adult persons 42.30%, death 57.370%. Next. Classification of adult persons among hormonal therapy and non-hormonal therapy. The higher result is hormonal therapy person receive higher survival rate 51.50%. Next slide. The year-wise calculation, 2022, the higher rate of death in breast cancer persons. Next slide. This is the main concept of the study, survival of hormonal and non-hormonal therapy. Hormonal therapy has higher survival rate, and non-hormonal therapy there is higher death rate. Next slide. Survival rate is unless using calculation survival. This is for hormonal and non-hormonal therapy. Hormonal therapy has higher survival rates, as shown in the graph. Next, survival analysis of letrozole versus tamoxifen. This is hormonal therapy, but these two are letrozole and tamoxifen. Letrozole has higher survival rate than tamoxifen. Next, this is standard mean, and I using SPX 18.0 software to analyze standard mean value, the age, weight, and the basal mass index is calculation. Next, this is conclusion. Patient receiving hormonal therapy has greater survival rate than non-hormonal therapy, and letrozole has greater survival rate than tamoxifen. Next. Thank you.
The slides, you go back. From last, before that,
before. இதுக்கு முன்னாடி The percentage of allowed is 20.16 in non-hormonal therapy and hormonal therapy 18.16.
Yes, sir.
Okay?
Yes, sir.
So what is your conclusion?
Sir, there is death rate only, sir. Death rate increase in non-hormonal therapy only, sir.
Death rate இது அதிகமா இருக்கு. 36.39 இருக்கு. ஹார்மோன் எடுக்கிறது நல்லதுன்னு சொல்றேன். அதுக்குன்னு ஹார்மோனல் தெரபி இஸ் குட். நமக்கு இந்த ரிசர்ச்ல எத்தனை பேர் இறந்தாங்கிறது நமக்கு வேண்டாம், எத்தனை பேர் உயிரோடு இருக்காங்கிறது தான் வேணும். ட்ரீட்மெண்ட் இஸ் ஃபார் சர்வைவல். சொல்லி நமக்கு புரிஞ்சுச்சா? ட்ரீட்மெண்ட் கொடுக்குறாங்கன்னா எத்தனை பேர் உயிரோடு இருக்காங்கிறது தான் நமக்கு கணக்கு பண்ணணும். கரெக்டான நான் ஹார்மோனல்ல 20 இருக்கு, ஹார்மோனல் 18 இருக்கு. நமக்கு தேவை அலைவ் பேஷண்ட், ஒரு கேன்சர் பேஷண்ட் அவங்க உயிரோடு இருக்கிறதுக்கு எந்த தெரப்பி பெஸ்ட் அந்த கம்பாரிசன் பண்ணி இருக்கணும்.
சார், நான்-ஹார்மோனல் தெரப்பில நிறைய டைனமிக்ஸ் இருக்கு சார். கீமோதெரப்பி, ரேடியோதெரப்பி, சர்ஜரி.
கேன்சர் அதை பார்க்கவே வேண்டாம், உயிரோடு இருந்தாலே போதும். என்ன சைடு எஃபெக்ட் கேன்சர்ல போய் பார்க்க போறீங்க? இறந்து போறதுக்கு தீர்வு. ஸ்ட்ரகிள் பண்ணிட்டு இருக்கா, அதுல போய் கான்ட்ராக்டிகேஷன் சைடு எஃபெக்ட் பார்த்தோம்னா 10 நாள் 15 நாள் அவங்க உயிரோடு இருந்தாலும் மற்ற டிசீஸ் தான் இந்த கம்பாரிசன் பார்க்கணும். அது இறந்துடுவாங்க, 1 மாசம் அதிகமா இருக்காங்க, அந்த பலி கொடுத்துட்டு போயிருக்கோம். அலைவ மட்டும்தான் நம்ம கணக்கு போடுறோம். சரிங்களா? எல்லாம் எடுத்துக்கிறீங்க டேட்டா, கால்குலேஷன் அப்படி போடுவீங்க.
சரி.
Thank you, Shanmugha Pandi. Next, I would like to invite Shanmugha Priya from Shanmugha College of Pharmacy.
Good morning to honorable person here. Myself is Shanmugha Priya. I am from Department of Pharmacology, Shanmugha College of Pharmacy. My topic is 3D printing technology in pharmaceutical product and its applications and now and future in overview. First, commercially technologies created by Jungle, stereolithographic methods of photopolymerization of liquid resins in UV visible light. In 80s, cut from filled that fused deposit model, techniques of thermoplastic material. In 90s, M.G.R 3D dimensional printing techniques are binding materials. In traditional, it is 3D printing is otherwise called as additive manufacturing. It is a computer-aided designs. Drugs are slided by layer, manufactured by 3D product. In research and development, 3D printing technologies is emerged by one after one. New 3D printing technologies are available. 3D printing technologies are in different materials, different deposition techniques, layer manufacturing mechanisms, and final products are characteristics in different materials, different drug substance, different level of doses. 3D printing technologies are 7 characteristics, mainly technical principles, name material extraction, binder jettings, powder bed fusions, VAT photopolymerization, material jettings, direct energy deposition, and sheet laminations. 3D dimensional techniques is widely used in automotive, constructions, medicals, and many other fields are used in 3D dimensional structures. Pharmaceutical sector, it is a global bomb. 3D printings are flexibility to design the drug in different doses and combination of drugs in one single tablet. To release a wide range of clinical needs, it high degree of flexibility and creativity of a pharmaceuticals company. Benefits of 3D printings are increase the solubility of drug and repeatable in accuracy, dosage specific parameters, unique dosage form in on demand, faster trials are occurred, microdosing without oxidation, non-contact processing of drug interactions. Three-dimensional printing technologies are used in manufacturing variety of drug products like immediate release tablet, controlled release tablet, microneedles, implants, transdermal patches are example for three-dimensional printing technology. In pharmaceutical, mainly binding jetting 3D printing technology, fused dimensional molding technology is maximum used in pharmaceutical companies. 3D printing technologies advantages of health and safety of elder patients or children. Children patients are growth development and reactivity of the medications. Elder patients are reduce the absorption and metabolic capacity to exist the multiple diseases and combine with very common disease. 3D dimensional printing technology are flexible to adjust the medicines in model parameters like size, shape, and fill rated. In pediatric patients, they are suitable in taste, appearance, and increase the stability. To improve the patient's counts, 3D printing technologies are prepared in loose or porous preparation. Take medications, multiple drugs at same time. In participant, combine a single tablet to avoid the error and mistake drugs. To increase the safety and efficacy of the medication in 3D printing technology, in different symbols of drugs, shape and size of the drugs. Price control drug release or 3D printing technologies or conventional tablet controlled release preparations are available in the 3D printing technology to improve the efficacy and the effect, avoid the side effects. It's greater challenge to control the release preparation and manufacturing. It is flexible to suitable for all the patients in all the ages of patients. In different drugs in different combination to adjust the printers to parameters. Rapid integration of products are large scale productions are commonly traditionally used drug substance in single type of equipments and lacking of flexibility and cleaning the equipment. But 3D printing dimensional technologies are fewer productions in one step but multiple drug substances. Principles of binding jetting 3D printing technologies are applied by solubility of API, that active pharmaceutical substances is insoluble, but binding jetting 3D printings are improved the relevant studies in active pharmaceutical ingredients. For example, hydrophobic active pharmaceutical வந்து குளோட்ரைமோசோல் மாடல் ட்ரக்கா நம்ம எடுத்துக்கிட்டோம் அப்படின்னா ஹைட்ரோஃபிலிக் எக்ஸிபியன்ஸை வந்து நம்ம லாக்டோஸா வந்து நம்ம கன்வெர்ட் பண்ணி வெட்டிங் ஏஜென்ட்ஸை இன்க்ரீஸ் பண்ண முடியும். இதுல வந்து எக்ஸ் அண்ட் ஒய் ஆக்சிஸ் ஆர் நாசில்ஸ் மூடு, இஜெக்ட் ஆக்சிஸ் ஃபர்ஸ்ட் கன்க்ளூட். Futurely, 3D printing technologies are involve individual person to produce itself to design and material process in drug substances. Sir, இப்போ
Previously, our compounders are given like this only, no? Previously. Now we are changed into common for paracetamol 500 for all. In future, we are going personalized how much paracetamol we need for a particular patient. Like this. So we are going back or front? Front. Previously, compounders are given like this only. We compounded 2 days after that we will get the medicine and we will give any specific see previously we given for same technology, we don't know the name 3D printing, but before that we olden days we given for compounding and we given. That time we don't know this, what happened, the specification, pharmacological action, that much level we don't know, but anyhow we given. But after that only, that time technology is not developed, so we shifted into the common platform. Now we are going for specific things. By using the gene, each and every person of the gene level, the personal drug absorption capacity, how much is there, according to that we are going. So the technology development we are using for specific medicine. But that one for not for common, for cancer patient like this people, so we can use it very nicely. Okay, thank you. Thank you. One more thing, here don't come, so you come here and don't read. Okay, you tell your own way, that is the improving the presentation skill. Okay, thank you.
Thank you, Priya. Now moving on to the next participant, Lokesh from Shanmugha College of Pharmacy.
Good morning, all present here. Myself is D. Lokesh from Shanmugha College of Pharmacy. Today I am going to present the PPT of utilizing animal assist organ perfusion as a potential bridge to transcription strategy for human organs. Introduction. Today, nowadays, organ transplantation is a major procedure for organ transplantation. Is if one or several organs in our body were unable to fail to work jobs routine daily, means if we have provide as a so critical for the precious means, so we want to transplant an organ. Because in nowadays the increasing demand of the organ transplantable organs means, so promote the research to explore the alternative strategies to bridge a gap between the availability of organs and patient need organs. The new strategies are animal assist organ perfusion, emerge as a unique potential and a temporary transplantation organs. Means the animal assist organ have been it is a new strategy for UNIQ and potential for the transportation of organs. The organ transportation is a major life-saving medical procedures in individuals suffering from end stage of organ failure. In traditional periods, where the organ transportation are preserved the organs by cold storage method. The cold storage methods are have in limitation to maintain the organs viability over a prolonged period, because the organs are they are taken away from our body. It's have some viability in some 6 hours or 12 hours only. So for individual organs, For sometimes there are many maintenance requirements for the organs. So in marginal organs, we have to provide a individual criteria donors for the marginal organs. For the problems, we have innovative approach for animal models by the pigs are the major physiological similarity to humans. So we are innovating in the pigs. So in pigs, we have perfused the human organs in ex vivo under conditions that closely mimic the physiological homeostasis by providing a continuous oxygenation and nutrition delivery, and waste removal have improved the organ quality. Next. From these innovative advantages are it provide organ availability and decrease the risking pathogens of organs, by which means if you derive the organ from the body, it's very affected by infections or decreased, and pick out the similarities in human organs. Organ with available immediately, and from this innovatives, the organs are easily available, and electively we have take the organs from the pigs. And from this procedure, we have eliminated illegal trafficking and use of ordinary from the expert prisoners. And next, clinical trials and experimenters are in case studies. We have preclinical and ongoing clinical trials. We evaluate the efficacy and safety of this animal assist perfusion of organs. By this, that we have innovating different typicals are the involve the perfusion of human organs such as kidney, livers and lungs with the blood of perfusion derived from animal models such as pigs or sheep. Then the immunological considerations mean if you have a transplant an organ from other bodies, we have immunological rejections, major acute hyperrejections. For that, we have the immune rejections are triggered by exome transplantations. The exome transplantation is there when we have transplant an organ from a non-humanal organ to the human organ, so it will known as the explantational transplantation. The channels of hyperacutes are derived from the major strategies developed such as genetic modifications and in the immunosuppressive regimes to the problems are overcome. But in this process, the donors and the host factors have major immune response in the rejections. Next. By this process, we have regulatory affairs landscapes or the regulatory ethics. We have to this process. We have need many guidelines and approvals for these procedures. From the Institution of Animal Care and Use Committees, I will provide an ethical reviews for the institution, IIC and equivalent agencies, but also ensure valuable products. Clinical trial approvals. The clinical trial approvals are animal assist have been provided and approved by the EMA and the FDA of United States, EMA by European states. Next. From this procedure, patients after transplantation outcomes are live ability to environment and life ability to individuals, external ability of lives, inner upstage of lives. After the transplantation, the humans are being providing a major life like a normal humans. Next slide, sir. And the organ explantations are done through the non-human organs. Chimpanzees liver is transported to human for several days for 70 days, and the bamboos, kidney, heart and liver are given and transported for 25 days or several days, and the pigs heart are provided to survival for the 35 days. So next. The heart explantation was from the in 1964 as Addis University of Physics. Chimpanzees orthotopic heart transplantation give small support to the circulation and give survival for 2 hours only, sir. And then in 1976, Brandy University of South Africa, bamboo heart obliterated transplantations heart support small circulation for 5 years only, sir. Like that, in 2022, Griffith University of Maryland and Medical Center fixed orthotic heart transplantation. There is an unknown cause of death for 2 months, sir. Next conclusion. In animal assist perfusions representation promise that avenue to improve the bridge gap between the transplantation outcomes. It may conclusion the animal assist perfusion world promise bridge and human organs. Continue research, innovation and collaborations are need to overcome the challenges. Thank you, sir.
அது என்னது அனிமல் அசிஸ்டட் ஆர்கன் பெர்ஃபியூஷன் என்ன?
சார் இப்போ ஹியூமன் ஆர்கனை வந்து நம்ம டைரக்டா வந்து இப்போ நம்மளுக்கு நிறைய இடத்துல டிரான்ஸ்போர்ட்டேஷன் சார். ஸோ தட் இப்போ அனிமலோட ஒரு ஆர்கனை வச்சு நம்ம ஹியூமனோட ஆர்கன் அனிமலை வந்து அசிஸ்ட் பண்ணிட்டு அதுக்கப்புறம் அந்த ஹார்ட் டிரான்ஸ்பிளான்டேஷன் அந்த மாதிரி ஆர்கன் டிரான்ஸ்பிளான்டேஷன் பண்றதுக்காக
ஜீரோ டிரான்ஸ்பிளான்டேஷன்
ஜீனோ டிரான்ஸ்பிளான்டேஷன் வந்து அதர் தென் அனிமல் பார்ட் சார்.
அனிமல் அசிஸ்டட் அப்படின்னா அது பிரிசர்வேஷன் டெக்னாலஜியா டிரான்ஸ்பிளான்டேஷன் டெக்னாலஜியா?
ப்ரிசர்வேஷன் சார்.
அப்புறம் சொல்லணும். ஜீரோ டிரான்ஸ்பிளான்டேஷன் வேற, அனிமல் அசிஸ்டட் வேற. இது ஒரு பிரிசர்வேஷன் டெக்னாலஜி.
எஸ் சார்.
கோல்டு ஸ்டோரேஜ்ல வைக்கிறதுக்கு பதிலா இது வைக்கிறோம். இந்த அட்வான்டேஜ் ஆஃப் திஸ் ஒன்
சார் இது வந்து ப்ரிசர்வேஷன் வந்து நிறைய ஈஸியா பண்ண முடியும் சார். அதனால இது வந்து இப்ப நம்ம நார்மல் லைஃப்ல வந்து இப்ப ஆர்கன்ஸை வந்து ஓவராலா கோல்ட் ஸ்டோரேஜ்ல ப்ரிசர்வ் பண்ணுவோம் சார். அதுக்கான வந்து நிறைய
கோல்டு ஸ்டோரேஜ்ல வைக்கிறதுக்கும் பர்ஃபியூஷன் டெக்னாலஜில வைக்கிறதுக்கும் என்ன டிஃபரன்ஸ்?
அதுல வந்து
அட்வான்டேஜ்
ஆர்கன் வந்து புக்கிங் கண்டிஷன்ல இந்த பர்ஃபியூஷன் இதுல வச்சிருந்தா இருக்கும் சார். நான் கோல்ட் ஸ்டோரேஜ்ல வந்து அந்த பிளட் சர்க்குலேஷன் அதெல்லாம் எதுவும் நம்ம இது பண்ண முடியாது.
ஆக்சிஜன் சப்ளை இருக்காது, நியூட்ரிஷன் சப்ளை இருக்காது. இது ஒரு பிரிசர்வேஷன் டெக்னாலஜி தான், டிரான்ஸ்பிளான்டேஷன் டெக்னாலஜி இல்ல.
எஸ் சார்.
கரெக்டா?
எஸ் சார். தேங்க்யூ. தேங்க்யூ சார்.
Thank you, Lokesh. By this, we end our morning session. A good lunch fuels productivity and sets the tone for the rest of the day. Lunch is served at H block. Please have your lunch and gather back at 2:15 p.m. Kind note, the participants for afternoon batch, please submit your PPT files to the scientific committee. நேத்து கிட் வாங்காதவங்க யாராவது இருந்தீங்கன்னா இன்னைக்கு இருந்து வாங்கிட்டு போங்க. கிட் நிறைய எக்ஸ்ட்ரா இருக்குன்னு சொன்னாங்க. I request all the students to come fast and please be seated.
Very warm good afternoon to all those who are present in the hall. I'm extremely happy to be a part of this recent innovation in pharmacology research hosted by the Shanmugha College of Pharmacy. I deeply thankful to the management and the principal, Dr. Suresh sir, and Vice Principal Perumal sir, and the organizing secretary, our friend Gobala Satish Kumar. So today, my topic is related to somewhat what was the advancement is happening there in the research field, both in clinical research aspects. So my topic is unveiling the future of drug development, navigating innovative strategies, challenges, and breakthrough. So first of all, if we are with preclinical studies or clinical studies, at least we should know about what was the drug. All the aspects we are going to develop a drug molecule that very beneficial towards the living organism, right? So as you know that the drug is nothing but simply we can say that it's a chemical entity using for beneficial of the human beings or living organism, and the source it may be vary from the plant source or animal source or whatever it may be. So creatively you can say that the drug can be seen as a molecular storyteller. What that means if you are taking any drug inside the living system, they may link any cell to cell, and what is going inside your cell, it will tell all the story. So that's why the drug can be as a molecular storyteller, whispering nuanced narratives or to the cells of our body, shaping physiological responses and altering the tapestry of our experiences. So nothing but in short form of drug means if you are improving our physiological functions or any kind of pathological condition with the help of any chemical entity means drug, right? And as you know that if suppose if you want to develop a one drug molecule, it is a long-term process. It may take 12 to 15 years of hard work behind to make a molecule. For example, paracetamol, whatever we are using nowadays, all the drugs is coming from within a 10 to 15 years of as a long-standing work behind to develop a drug. So first of all, if you are talking about drug development, first you should assign one drug molecule, the source, and from before that one you have to make one target selection. What was the target? What are the causative disease will happening? One molecule will be there. That molecule should be the target. So target you should select. From that you should go for a lead discovery, and from the lead discovery you have to convert into that chemistry aspects, and that chemistry you synthesize the molecule from the synthetic way, go for the in vitro study using cell line. After that you should go for if you are getting a good data in your in vitro cell line, you can go for the in vivo animals, that is a preclinical studies. And what we are getting the data from the preclinical studies, observe very keenly, and if the company fellows are very much interested towards your preclinical database, they will sponsor the work, or they will catch over or take over your product for development of a clinical aspects, right? And after that, if you are getting a good data from the preclinical studies, next was the clinical trial. That is a phase 1, 2, 3, and 4. The 4 is nothing but it's a post-marketing survival, right? So this is all together drug development timeline, which may take 10 to 15 years, and it may around $800 million for an expense to develop a drug molecule, right? And this is the timeline of drug development. So starting with the animal model, it started by 1908, then an animal model, and the phage was discovered by 1917. The aspirin, as now we are using as a very promising drugs towards to the for those who are getting the atherosclerosis or by getting any kind of heart attack after getting angioplasty, as a lifelong they are prescribing a drug called aspirin. So aspirin, if the dose dependent manner, there is a two uses. If you are using by the aspirin by low dose, it is a platelet aggregator, antiplatelet aggregator. If you are using by the high dose, it is an analgesic. That means 75 mg if you are using by aspirin is an antiplatelet aggregator. If you are using by 375 mg per kg, that is an analgesic, right? So that is developed by 1897, and what we are looking for the green color, all are related to the antimicrobial peptides. Peptide is a small molecule. Nowadays, all the company or those who are keen into develop a drug molecule targeted to the peptides only, small molecule peptides. So all the green color we are observing in the picture is related to the antimicrobial peptides, and what we are getting in the yellow color, it's related to the antibiotic development, and the black color boxes are denoted to the related to the drug resistance, and others are the important events in drug discovery and development. So 1900 is started by the animal model. Then once comes to the 1941, there is a penicillin clinical trial happen. As you know that penicillin is discovered by accidentally, Alexander Fleming, and after that is get into the clinical trial by 1941, right? And gramicidin 1931, that is an antimicrobial peptide, and black color PRSA, penicillin resistant Staphylococcus aureus, MRSA, methicillin resistant Staphylococcus aureus, all are controlled by or are reported by the 1960s, and the PCR, polymerase chain reaction process, was developed by the 1985, and recombinant DNA technology by 1973, and Klebsiella pneumonia. And first the WHO informed there is a huge lack of antibiotic will happening in the future days. Why? Because all the bacteria are very well resistant to the existing antibiotics. So still they are very keen to develop an antibiotic which can able to kill the microbes. So this information passed by 2001, the WHO declared drug resistant global concern. That is happening by 2001. Since 20 years was happening. Till now, we don't have any new drug development in career. So existing drug, they are trying to get into the antibacterial effect. So this is what's happening by the 2001. And Klebsiella pneumonia resistance for all antibiotics happened by 2016, and 10 million deaths per year due to antimicrobial resistance will happen by 2050. So 2001, the WHO declared that there is a very crucial point will happening by the resistance of bacteria. So they are expecting that 2050 there is a 10 million deaths per year due to the lack of antibiotics. The resistance, development of resistance due to the antibiotic may lead to this much of death in the 2050. So that is the timeline of drug development, and drug discovery happened because of two reasons. Either by accidentally, that is we are known serendipity. The oldest one is serendipity. Serendipity means that discovered by chance or trial and error method. So in this way, the first drug was happening by the penicillin by Alexander Fleming, and Flory and Chain have gotten a Nobel Prize on the penicillin by 1945. Same way, the chlordiazepoxide, the first benzodiazepine was discovered. The drug also get from once they are trying to get into one dye. From the dye only they got the chlordiazepoxide. And second thing, cyclosporin. You may know your UG and PG syllabus. The cyclosporin mainly coming under immunosuppressant. Those the drug we are using for the organ replantation to suppress the immunosuppressant effect, and sometimes using as a medicated stent. Those who are getting the angiogram and angioplasty, they are using a medicated stent. So the medicated stent is coated with the sirolimus. So sirolimus is an immunosuppressant drug. Previously, they are testing for the anti-tubercular. By accidentally, they came to know that cyclosporin have the capacity to decrease the or control the immunity. When you know that the sildenafil. So sildenafil is the drug which may prostaglandin analog we are using in a peptic ulcer condition. Now they very widely used as a Viagra, right? So this is happening by accidental way of drug development. And second thing, if you are making a drug development because of the chemical modification intentionally, we know that some chemical structure have some kind of mechanism of action, so we have to improve by to modify by the chemical alteration or modification. That way we are getting the first drug was aspirin, salicylic acid. They made an what do you say, chemical modification, and they got the aspirin. And second thing, the ranitidine. Ranitidine, they made a what do you say, chemical modification from famotidine. So famotidine is the drug. Why they are making all the chemical modulation means famotidine have the anti-androgenic effect and some unwanted adverse reaction. To overcome the adverse drug reaction, also we are always looking forward to develop a new drug molecule. For ranitidine, from the chemical modification, what was the basic drug? Famotidine. And next one, pindalone. Pindalone also one type of antihypertensive drug, which also have modified by the propranolol, beta blocker drug like a propranolol. They made a chemical modification and they find the pindalone. The drug have a very safety area, right? And second thing, and third one is the most important drug screening or development technique, that is a virtual screening of database or virtual or by high throughput assay. In that one, they made one drug was frondosil, and second drug is a paclitaxel. Paclitaxel is an anti-cancer drug, right? And fourth one is the usually now all the drugs have developed by in silico method. From the in silico method, they are using by this technique only. Most advanced technique method for drug discovery is a rational drug design. This rational drug design, nothing but drug design begins with an identification of biological target. We are just identify the biological target. To the target, we are developing or we are creating one drug molecules towards the target, and we are developing the drug. And in that one, there is a two concept. The first concept is a ligand-based drug design, and second concept is the structure-based drug design. So what do you mean by ligand-based drug design? Ligand-based drug design, nothing but we don't have the macromolecule or biological molecule structure. We have that what is a ligand is nothing but we can compare with the drug. So we have the drug molecule structure. So we are assuming that the structure and that drug structure and affinity, we are assuming that this drug can be bind to the biological receptors. So that is why we are making a drug molecule or ligand, and there we are assuming that it can be bind to the macromolecule. Second concept is the structure-based drug design. In that one, we know that a macromolecule is nothing but that is the target molecule. Any kind of disease will happen means there is one biomarker will be there, or any kind of protein will be there behind the disease. So that protein will be the target molecule. So into the protein, we know the structure of protein. According to the protein structure, we are developing a ligand, that is a drug. So this is the two main approaches for drug design. And what was the drug design history? So 1890s early, Emil Fischer compared the drug receptor interaction to the key and lock interplay. So they Emil proposed that this is the key and lock mechanism will happening only all through the mechanism by the solidified manner. There won't be any kind of conformation change will not be occur. That was their statement. After all, there is a Daniel confirmed that if is there any kind of drug receptor interaction will take place means there is a drastic conformation changes will happening throughout the procedure. So that way they conformed with the extra structure and in silico simulation. So finally they conformed with the extra structure and in silico simulation that if there any kind of drug and receptor will happen to the interaction, there is a drastic changes will happening inside that drug molecule and receptor, and the locking will happen. That is the history of drug design. And we know that the target macromolecules. What do you mean by target macromolecule? The target macromolecule is nothing but we are targeting a molecule which may lead to the pathological condition, or if you are making any drug against to the biological target or macromolecules, it may improve your symptoms and you can improve your quality of life. So that is the macromolecules. So Now till date, there is a 20,000 protein coding genes in human genome. There is a 20,000 protein coding gene in the human genome, and among the 20,000, only 3,000 had been estimated to be part of so-called druggable genome or druggable protein. So out of 20,000 genome, protein coding genome, only 3,000 have been now discovered that protein have or gene have to ability to interact with the drug, right? And this is the overall druggable proteome divided according to the target development. There is a clinically non-protein, that is only 3%. The clinically non-protein, that means in that protein we have the drug molecule. So if you are having any kind of protein expression will happening to that particular 3%, we have the drug to counteract the protein effect. That is a clinical non-protein. And second thing is a chemical non-protein, that is a 6%. That means target including proteins known to bind with high potency small molecules that are not yet drugs, that are not they are not developing a chemically non-proteins, still they are under developing for the drugs known to the chemical non-proteins, and 53% of is the biological non-proteins. What do you mean by biological non-protein? Biological non-protein target refers to the protein that have linked to any disease but not been studied for binding to small molecule. So existing there is a more than 50% of biological molecules still we have to develop, and we have to discover a new molecules towards the biological non-protein, and 38% is the dark proteome, that is still we don't have nothing, any kind of data, we don't have any kind of data regarding to the 38% of proteome, that is a dark proteome. The dark proteome includes the unstudied proteome. So still there is more than a 20 or 30 years has to go to maybe identify the dark proteins in the human genome, right? And next thing, what was the current method for to develop the what is the drug design? What was the current? So now you know that all the very familiar words like AI, artificial intelligence. So all through the drug design, whatever we are doing, any kind of thing, if you are playing in the PUBG in between the class or something, all are controlled by the artificial intelligence only. So these artificial intelligence have the vital role to develop a drug design. Why we are implementing and why they are focusing on the artificial intelligence means they are very, we can save a lot of time to develop a new drug molecules towards the disease condition. So currently artificial intelligence has invaded drug discovery in all aspects of this process. In drug design, AI used to predict 3D structure of protein, drug-protein interaction, drug activity, construction molecules, de novo. So if you are implementing the AI in the drug design, we should know about what was the structure of protein in a 3D way. What was the binding local task percent? What was their affinity? What was the capacity? What was the affinity will comes? All we can do with the artificial intelligence. And in pharmacology, if your AI is used to design specific molecules as well as multi-targeted drugs. If you are using by pharmacological aspects, we can design a drug molecules for more than one target of protein at a time, right? And in chemical synthesis, I is able to design synthetic route, predict reaction yield to clarify reaction mechanism. So in chemistry aspects, they want to synthesize a compound, and they can synthesize the compound. They have to evaluate with the in vitro or in vivo analysis. For that purpose, they can get into the synthetic route by with the assistance of AI and predict an reaction yield. So what was the product? How much we will get for this kind of reaction? What was the yield we will get? That can also we can predict through the AI. So this is the concept of AI in the different aspects in chemistry, pharma, drug design, and undoubtedly we can say that AI is a screening for predicting toxicity, properties, chemical properties, etc. So this is the timeline of AI get into the market. So we know recently only we came to know that AI have a huge role into any kind of thing, even if you are making a Google map. The map, if you are any kind of, you are taking by the wrong route, that information will comes, or they will direct you in the different route of way to reach your locality, right? So that is also one type of AI they are used by the Google map. So these are all to the timeline where the AI was implemented. So see, the first 1642, the first mechanical calculating machine built by French mathematician and inventor Blaise Pascal. So that is the first clue happened there to develop an artificial intelligence in the science. And later on, all these are the timeline happening there at the end. And the latest one happening by the 2018. Most universities have course in artificial intelligence. So instead of making, you maybe feel that some way you will get some phone call from other end, and if you are saying hello, they may wait for 2 seconds and then they will start by your voice from the other side. So finally, after 2 seconds, you may realize that the voice is behind to some machine, not by the human. So that is also happening by nowadays in the all the way of AI. So this is the current trend. University also implementing their artificial intelligence to run a course, right? And AlphaGo beats professional job league, Sidol 4-1. The artificial intelligence plays a role in the game as well. So there are artificial, if you are talking about artificial intelligence, there is a two aspects and develop the artificial intelligence. One aspect will be based on the capabilities. That means three are the artificial by narrow intelligence. That is the one type of capability that can produce by the AI. What is the artificial narrow intelligence? ANI. That means if you are giving that machine can only give the specified in one area and solves one problem. If you are giving that we are making one algorithm or we are feeding one type of problem solving into the AI. So if you are giving any kind of problem related to the invading or related to the feeding, they will rectify the problem. That is the artificial narrow intelligence. Specialized in one area and solves one problem. That means Siri, example Alexa, Cortana. These are the examples for artificial narrow intelligence. And next thing is then artificial general intelligence. That is means if you are giving any kind of refers to the computer that is as smart as a human across the board. If you are giving any kind of question towards to the Google or something, they will reply according to your prompted questions, right? That is coming under artificial general intelligence. And third one, depending on the capabilities, artificial super intelligence. So that is a third stage of artificial intelligence. That means an intellect that is much smarter than the best human brains practically every field. So if you are making the artificial super intelligence, now all the way they are to developing in the smart way only, so they can think their way. We are making a lot of algorithms in their screening, and they can think like a human or more than that they can think. So they will solve what are the problem we are giving, or they will solve by this kind of super intelligence. So these are the three concepts laying down the base on capabilities. And second thing is the artificial intelligence is on functionality. So the first one, reactive machine. Reactive machine, as far as we can concern with the artificial narrow intelligence. That reactive machines means if you are giving any kind of one problem, they will solve and they will give the answer to that question. And second thing, limited memory. Limited memory means they will not store their memory in a long way. They will make the question, they will answer the question, they will erase. So there is a short-term memory, that is a limited memory. And theory of mind. Theory of mind means that is the example for Google Map. So if you are making a Google Map, you are making in a one route, and maybe by accident or by anything, if you are taking in any other wrong direction, the map will guide you how to reach the destination. So they won't tell you that you are going the wrong way, you turn back and turn left. No. They won't give any kind of suggestion. They will give you extra suggestion in which way, if you are going, how you will reach your destination. So that is coming under the theory of mind, and self-aware is nothing but as a human being. So all the emotions, all the feelings, and what we are thinking about all the occasion, they will think like in a human. So that is coming under self-aware. So this is a two concept of AI. One is a capability base, and second thing is a functionality base, right? And if you are talking about the artificial intelligence, it's a very broad area. So in that one, there is a two more compartment is there. One is the machine learning. Machine learning is but algorithms whose perform improve as they can expose to more data over time. If you are giving thousands of data per second or whatever it may be, they will give you a clear-cut solution for that one. That is a machine learning. And the deep learning is again subset of machine learning. So AI is the broader concept. Under the AI, there is a machine learning. Machine learning, that is a subset is a deep learning. The subset of machine learning in which multi-layer neural networks learns from vast amounts of data. That is a deep learning. You may be heard about the Tesla. They may run in neural network, one company. One person is fall down the heights and he is completely paralyzed. He made one chip over his brain and he is playing with the chessboard with the computer. So how they will move the chessboard through maybe the paralyzed person. So if you are inserting chips, they will control by the AI means what we are thinking, what was our imagination, all will detect by the AI, and they will instruct the game, and they will move the what they want to play with that game. So that's why this deep learning may be an important role in drug discovery. And these are the common users in AI. What are the applications there in the AI means? You can apply the AI in the gaming, what we are making, and you can apply in the automotive and robotics and social media. Example, if you are searching any kind of product there in the Amazon, if you are parallelly, if you are open by your LinkedIn or whatever the thing you are opening, the same what you are searching in the Facebook or whatever, it may reflect in your LinkedIn. So it all are connected with it. What are the data you are producing your web of search? So they will collect and they will give you the information. This product is now available. You just go and check in the Amazon. So all will happening with the AI, artificial intelligence only. You may feel that in the social media and education, as we saw that so many universities are started by the robotic for education level, and agriculture means they will detect what the time for to paddy cultivation, what was the climate, they can predict the raining, how it will, when it will come by the raining. So that kind of things will give by the agriculture. And the transportation, we already told that mapping. If you are making the map, if you are taking a wrong direction also, they will divert you into the correct diversion. Then healthcare, astronomy, finance, data security, in all the way that AI there is a promising role to play, right? And now we are talking about the healthcare or drug development. So there is an AI, already we are talking about the AI now they are using for the drug design. So what was the platforms, AI platforms we are using for to develop a drug molecule? So Swiss drug design system developed by the Swiss Institute of Bioinformatics. That is the one, one AI assisted drug design platform or tool. They are developed to synthesize the, to help to synthesize the drug molecule. So the name is Swiss Drug Design. The platform is very freely you can access by the EPSLI portal, that is www.expsay.org. If you are going with that platform, you can download the Swiss Drug Design, and along with that, you can develop your drug design. And in that one, what are the subsection you can see there in the software means? It consists of several modules. If you are making Swiss doc means molecular docking, you can perform. And if you are going by the Swiss ADME, you can predict by the pharmacokinetic and the drug likeness prediction. And if you are going for the Swiss similarity means virtual screening you can do. And if you are going Swiss biostate means you can go by the lead optimization. If you are go by the Swiss target prediction means you can make the target prediction in the small molecule. So all this kind of subsection or the molecule side, they will give by the cis molecule. According to what you are going to predict ADME, whether is you are going for the predict for ADME or by lead optimization or for the target prediction, you can use these softwares to predict the drug likeness, right? And the second thing for to identify the 3D protein structure. If you want to make the drug molecule in a 3D way, you can analyze what was the 3D structure of the molecule. You can go for AlphaFold. AlphaFold is the one platform which way you can use to 3D protein structure based on solely into the amino acid sequence developed by DeepMind and EMBL EBI. So that is all protein or 3D structure they will developed by the sequence of amino acid, and this site was there maintained by the DeepMind, right? And next, for example, a recent aspect 114 assessment show the AlphaFold demonstrate that most accurate prediction in 3D protein structure with medium backbone RMSD. RMSD less than 2 is the highest Armstrong rating once we are going for the 3D protein project. So with the help of AlphaFold, they finalized, they got a good result with the assessment of Casper 14. So this site also you can go for to predict the 3D protein structure. And the next thing is the Merck Synthia. Merck Synthia is nothing but the platform you can propose possible synthesis routes for a given compound. If you have any characteristics compound, you can go by the synthesis route by the help of AI assisted platform that's known as Merck Synthia. Right. And next one is a Cycloidea Ligand Express. Cycloidea Ligand Express is nothing but the platform, the possibly protein target for a given small molecule. If you are making any molecule, any synthesizer molecule, characteristics of small molecule, we can predict what was the protein may be targeted for the drug molecule. So if you have a drug molecule with the full characterization, you can predict which protein can affinity towards the drug. That can also you can check with the Cycloidea Express. And next one, AstraZeneca is the one leading medical company. They are making one AI platform that you may be heard about that de novo design for small molecule. This AI platform is developed by the AstraZeneca only. You can freely available in the site. You can go for the site means you can make it into the de novo design for the small molecule. And next, these are the techniques you can make the 3D structure synthesis wise. You can predict the protein, what was the industrial protein regarding your drug, all the way. Unless you are not making any kind of visualization, that the study will not be fulfilled. For visualization purpose, we should go for the molecular dynamics. In molecular dynamics, if you are following the molecular dynamics, they will give the van der Waals force, they will give, and intra and intermolecular strength they will give, hydrogen bonding capacity will give, and a lot of hydrophobicity they will give. So all this kind of data will only we will get to the molecular dynamics. So once you are predicting your 3D structure and you are making the synthesis and whatever you are doing, you should know about what was the drug and macromolecule, what will happen due to the long-term treatment, is there any changes, and what will happen in the hydrogen donor or hydrogen bonding, is there any changes will happening or not, all we can visualize with the help of molecular dynamics, right? And for the example, they implemented the University of Manchester, they implemented AI-assisted 2 robots named as Robots Adam and Robot V. Away. So Robot Adam is giving, or they are constructed by the Rose King and Stephen Oliver from the University of Manchester. What was the function of Robot Adam? Adam will always construct the microbiological experiments. What are the experiments we need to conduct through that lead molecule? They will develop by the Adam robot. Experiment and analysis of result itself, and define hypothesis, design experiment to test this hypothesis and repeat the cycle until validated hypothesis derived. So with the help of robot Adam, they will do the microbiological assay and they will make one hypothesis and they will run the robotic will run all the way to the repeatedly, multiple 4 times, 5 times, 10 times until your hypothesis proved by repeatability. Until that time, they will make they will change the hypothesis. They will perform the microbiological assay. They will give you a pure hypothesis and they may validate your result and they will correlate your result and hypothesis correlate which each other means. They will, that way they will help you like a robot Adam. And what also function of robot Eve? Eve is more advanced robot. She is able to screen experimentally thousands of hormones per day. If you are by a human being, if you are sitting in your super computer or whatever it may be, there may be, you can, in a 1 minute or 2 minutes, you can run by one drug only. So with the help of this Eve as a robot, they are making, that robot is making, screen experimentally thousands of compounds per day. They don't have any frustration to do the repeated job. They will do their mechanical way. So that is the way they are making by the Eve. And to discover specific hits, they are discovering the hits and to engineering specific cell line to test the hits and then to optimize their structures to deliver lead compounds. So the robots Adam will do the all the microbial assay. Robot Eve will do the all the screening pharmacological assay per day, and they will also develop a hit. Hit is the target molecule where we can develop the drug against the molecule, and they will give the specified cell line specification. Those the drug can be able to give any kind of response. That cell line also they will engineer. They will help to engineer and optimize the structure to the lead compound. What was the exact structure wise, the lead compound structure wise, that also will lead to that. So that is the now the very promising AI tools there in the drug discovery. Then this may be the future of drug discovery. So what we are expecting or what we are talking about nowadays, all they are following, all this kind of software they are making to identify the lead, they are designing, they are making some ADR, they are making some toxicity, they are making some kind of thermodynamics or some, they are doing. And what may be the futuristic? So futuristic drug discovery, we can say that it's the synergistic. Synergistic is nothing but 1 plus 1 is equal to more than 2, right? So this is the synergies of edge computing and Internet of medical things and deep learning. So next discovery will happen because of these things only. First one, edge computing. Edge computing is nothing but you can say that is there any cloud storage, and when device is there means this is a mediator. If you are making any data there in our mobile, this data will store in the cloud. So to reach the cloud, there is a mediator will be there. Exactly that is the same thing happening there in the edge computing. And Internet of medical things means by through the phone call or by to any software. If you are uploading any kind of your data, if they will develop a software saying that once you are taking the tablet, what was your feeling? You may be feel lethargy, or you may get any kind of feverish, or you may have any kind of headache, or what was the feeling you are getting. So you can feed it into the software. So that one also will collect as a data, and there may be deep learning. So individually, if I am giving the entire 100 or 1000 population for the paracetamol, so each and everyone have a different opinion maybe. So in that different opinion, if you are by manually, if you are collecting, there may be a bias, there may be error will be coming. So if you are making any kind of data through the software, they are collecting all the data in the one cloud storage. From there, they may analyze very deeply. From there, they will conclude or finalize that if you are taking this drug, it will happen. If you are taking this the dose, it will happen. So a very clarity wise drug, what do you say, what was the use or what was the ADR or what was the discomfort and what was the current if you are feeling in the same drug over the population. So this is maybe the future of the drug. This is the same graphatical or picture-matic diagrammatic. First one is the layer 1. That means if you are, these are all they are forced to implement this corona time only. So after the corona time, they are very forced to do all this kind of data by the artificial intelligence. So once the layer 1 means virus identification, this is the schematic diagram representing for to develop a vaccine, right? So first one, layer 1 is in a virus identification based on cloud computing. So if you are reporting that this is the symptoms happening, so some maybe 10 member will give the same symptoms towards your infection, and another 20 they will give different opinion. So all the way they will collect, and they will make that what was the exact virus for this reason, right? And second thing, they may predict the suitable antigen or molecule profiling with a small molecule. So depending on the virus, they may making the antigen and beta cells or T lymphocytes. What was the immunological effects was happening with the virus? They will predict that they will image the based on small molecule profiling, and they made in the antigen. They make an antigen towards to that same exactly for the virus, and they may induce it to the animal. From there, you can make it to the protective immunity is there or not. We can finalize. After that, layer 4 is immunization layer. After that, what will happen? What are the data we are getting from the animal? That data will go for analyzing. If you are getting the good data from the animal, you can go for the clinical trial and animal and analyze for the human response. If you are once the virus is come means, they will collect all the data, they will feed it into that, they will finalize what was the structure of a virus, what was the binding pockets are there, what was the receptors that are present in the virus, all they will count it, and they will make into the what was a small molecule can able to bind into the virus. They will predict through the assistance of AI, and they will go for the preclinical studies. From there, they may make to the all clinical trials depending on the cloud storage. So this is maybe the future of drug discovery. 3 concepts: edge computing, internet medial things, and deep learning. And now we heard about some molecule, small molecule and biological. So what do you mean by small molecule? Small molecule is nothing but a small peptide. Small peptide. And what may be the biological? Biological may be the large proteins and maybe the antibodies. So biological, you just confirm with the antibodies, and the small molecules, you just imagine with the small peptide. So if your size means molecular weight 80 to 100, and the stability is usually stable at room temperature in small molecule, while if you are going for the biological, it's in a unstable in a room temperature, and the 3-dimensional structure is relatively very simple to make. And the biological means in antibody structure is a very complex thing. And the route of administration, you can go by small molecule by oral, and you can go by biological via infusion or injection. And the cell membrane permeability is very high in small molecule. Biological means very low only. And see the last point, competition, business aspects. So the companies, they are maximum they will develop with the help of small molecule on C. That is a very high in competition to develop in a company wise, where if you are talking about the biologicals, is a very less severe competition. Why? Because there is a very complex nature to develop the biological drug towards any kind of situation. So I will give you one example, then you will get into some idea. Small molecule and right, and see the thing. So according to small molecule and biological, we can make new type of treatment strategy. The name is antibody drug conjugates. That means antibody means biologicals, the drug means synthetic, any kind of lead, that may be small peptide as well. So if you are combined with antibody and drug, that conjugate name is ADC. So what was the concept? They are making a one antibody, and they make a linker. One linker will be there. In the linker, they made a one load, that is named as payload. The payload is the red color. You can see that the payload only the main responsibility towards the cytotoxic effect. So for example, if you are using by anti-cancer treatment, if you are using any kind of drug that is related to antibody drug conjugate, you can use by cytotoxic drug with the antibody. So once you are giving this drug by infusion, why they are giving this drug by the infusion? If you are this drug, if you are giving by any oral, it will degraded by the gastric enzyme. So to avoid the gastric enzyme degradation, we should give this formulation by the IV infusion or by IV infusion in by intravenous or whatever you can give by. So this red payload gives the cytotoxicity effect by the, sorry, yeah, responsible to address cytotoxicity. If you are giving by this antibody conjugating drug conjugates, it will detect the antigen there in the membrane and it is engulfing by the process of endocytosis. Through the endocytosis, this antibody drug conjugate get into the cell and lysosomal trafficking will happen. So lysosomal is the enzyme which degrading any kind of foreign material get into the cell. So it will also degrade the antibody drug conjugate. From if you are degrading these things, from what will happen that payload cytotoxic drug will release from the antibody drug conjugate. That cytotoxic component may kill the cancer cell line. So what was the advantage of this drug? This drug advantage means very specified. It will only will attach those the cells have cancerous in nature. So in the cancerous nature of cell, they will attract this antibody drug conjugate, get into the cell, and they will release the payload, and through the payload, they will kill the cancerous cell line. And these are the some drugs developed by the ADC, antibody drug conjugate, and these are the left side you can see that, and right side you can see that what is the target tumor cancer receptors, right? And for example, these are all ADC are developed and approved by FDC, approved by the FDC only. For example, tisotumab vedotin, the last one, tisotumab vedotin. This is the antibody drug conjugate. We can use in the cervical cancer where it will bind to the tissue factor. So what will happen in the disadvantage of this combination means if you are binding to the tissue factor, there may be happen to the thrombosis. Your clotting ability to may be loose. So hemorrhagic condition will happening once you are using the tisotumab. So tisotumab vedotin finally they withdrawn by the approved cancelled by the FDA recently because of the serious ADR happening with the combination ADC, right? And future direction of ADC means once we are saying that it is binding to the receptor will capture the ADC and release the playback and it will destruct the drug, and sometimes what will happen, unnecessary unwanted ADR will happen. So the future direction of ADC is that to improve the ADC design and delivery. To improve, if you are design and if you are improve their penetrability and delivery, you can improve your ADR as well, and you can improve the quality of patient. And the second thing is new payload with immunotherapy property or radiation property. Those who are giving cytotoxic drugs towards the antibody, instead of that one, you can also give radio-labeled things towards to the antibody, and you can insert or if you are giving by the treatment ways, it also may mimic the kind of chemotherapeutic effect or radiation kind of treatment. So that may be the future direction towards to the ADC development. So existing ADC development still have a lack of some disadvantages there. So through this thing, you can improve their advantage over through the drug design, right? And what may be the future of drug discovery or clinical trial or drug development in 2050? So now we are in 2024. If you are crossing by the 2025 and if you are reaching by 2050, so what will happening there in the clinical trial and drug development? What is the criteria behind to drug development and clinical trial? The first thing, we know that all nowadays we are wearing the smart watches, right? And some smart watches they will give, if you are sitting a long time, they will insist you or they will intimate you that just go for a walk, right? They will insist you to do some kind of activity. So that is happening because of the assistance of AI. So this will happening by the 2050. Nowadays, all don't have any kind of smart thing. So now, if you are passing by year and year, all will be dependent by the portable devices to monitoring your physiological alteration, any kind of thing. So first thing, implement a device for heart health monitoring. Now you know that in the smartwatch, all the smartwatch are having the heart monitoring. Their rate you can monitoring by the health device. And second thing, artificial tooth or monitoring temperature, nutrition, and oral health. If you are making, instead of being a new tooth, what they will do, they will ask you to insert by the artificial tooth. If you are making an artificial tooth, what they will get the data, what was your oral health? Is there any chances to get the oral cancer or not? And what was your temperature? And what was how much nutrient you are taking per day? All you can detect by the help of artificial tooth. And third thing, smart pill. Smart pill, they will ask you to take a smart pill. The smart pill give you a 20 to 30 days in your system, and they will monitoring your digestive enzyme and what was the pattern you are getting kind of food. If you are taking by the parota, what was the excretion of acid value, and if you are taking by the dosa or something, what was the alteration will happening, and what was the epithelial movement, and what was the pylorus, all will detected by the help of smart pill by monitoring the digestive system. Second thing, electronic tattoo. Now we are doing tattoo very normally. So once you are getting into the year-wise, there are some advanced in the electronic tattoo. And what will happen if you are taking the electronic tattoo means monitoring activity, steps and falls. So no need to wear a smart watch for your watching steps and your monitoring activity, then how much you are sleeping and what was the per day activity. All the way the smart or electronic tattoo will monitor and collect the data, right? And fifth one, acute or chronic delivery system. Sixth one, smart pillow. If you are using the smart pillow, if you are sleeping, they will detect how long you are sleeping in a REM, non-REM sleep. So that way they will collect your data. And scales, monitoring weight, body mass index and hydration. Contact lens, if you are making the contact lens artificially, monitoring sugar level, and they will give the what was your high health in general aspects. So these are the some futuristic electronic or AI mediated things which may mingle in our lifetime, right? And this is the thing will happening if you are making any kind of smart thing like an artificial tooth, pillow, and by the smartwatch, by any kind of contact lens, all the way they will collect the data. They will store in the cloud storage. They will make you the decision that this data will help you to design the drug, which drug may be needed to that person. So maybe you may be heard about the morning session class by personalized medicine. So personalized medicine depending on the each and individual person, what they need the exact medicine. So that way you can develop a personal medicine depending on the cloud storage. So each and every data will vary to depending on, you can develop a drug monitoring or drug thing. And how will health chips, wearables, diagnostics impact on finding their patients to do study. So if you are making by any kind of thing, now we don't have any kind of smart watches. In 2050, we all will implanted biosensor will commonplace by 2050. So 2050, if you are raising, these are just assumption only. We will force or we will try to implant biosensors in our body that may get into all the data what we need to develop ourselves to improve our health status. And we are already approaching true personalized medicine. The future will be dose being a term consigned to the past instead of drug delivery will be response. Now we are showing about dose. See, paracetamol means you should take by 500 mg. Now, if you are making any personalized medicine or if you are implemented biosensor in your body, the dose will replace by drug delivery will response. So what was the amount you need to get into the effect? That will be your dose. So the dose will not be fixed for all. So that will also will change to the 2050, and how that clinical trial will design, that I will speak. And this is the drug development for the traditional way by clinical phase 1, 2, 3, 4. And if you are making in the cloud storage or data analysis, you can go by preclinical registration by AI assisted platforms, and you will get the lead molecule to develop a drug against the disease. And in early stages, you will get the waiver from the, because of this deep learning, you will get the PACA data. So that data you can convince with the authority. So you will give the waiver in early phases. And if you are go by the safety licensing or clinical trial wise, there may be what will happen. Each and individual person will vary to the effect. So what person will get the effect, that person dose will come into the market. Others dose will be cancelled itself in the phase 1 to 3. So because of the personalized medicine dose, the drug development will be faster of enough in real-time registration agency. Then what was the reimbursement? Now we don't get the reimbursement. We should go for a lot of documents to get the money back for a treatment. Now what will happen in future, if you are giving the data yourself to the company or developer, they will pay you. So once you can bargain with the company fellows that I will give you my data, you just waiver your medicine value. So that is only reimbursement will happen there in the future aspects. And these are some most expensive drugs in the world. That is the last thing. Solgizna, that is the highest, paid medicine, $2,125,000. It's used, and it is used in the condition of spinal muscular atrophy. Then what may be the future of disease? The future of disease is nothing but we should force to rewrite the medical textbook for years to come, except there won't be any textbook. Why? Because if you are collecting all the data individually, all the data is with you, it may vary to me and yourself. So if you are referring any kind of textbook, it won't give you the correct proper answer. So nowadays in future, there won't be any textbook to study the medical condition or any kind of normal range or abnormal range. The data will tell the story about the disease condition. So the future is all about the data. So that is the future of disease. And if you are telling about the future of medication, that medication now, there is a repurposing option is there, nothing but the existing drug they are using for the another option of any kind of new purpose. And the second thing of future medicine is gene and epigenetic profiling coupled to biomarker targeted monitoring will see medicine able to hit hard and hit early. So if you are going for the genomic or gene mapping, and you can able to develop a drugs towards to the disabled way, because if you are making a genome level from your personal way, you know that what is the gene defect happening there in your gene, and you can either repair or you can replace the gene, and you can go for a better treatment way. So that is a future medicine, gene and epigenetic profile coupled biomarker. And what may be we are talking about the perception, we are just thinking that 2050 will happening, the biosensor and all the AI mediated things. But the thing is, as Vladimir Lenin, the Russian politician, what he say in the very early in the years, it is impossible to predict the time and progress of revolution as it is governed by its own mysterious law. So there is if you are going for the genetic or gene editing or something, there is a very issue with the law. The personal, our personal matter, or there is a very kind of issues will happen by the low way. So we can't predict this will happen by the 2050. Again, maybe before 2050 or after 2050, there may be, definitely there will be a revolution will happen. So that is why they are saying it is impossible to predict the time and progress of revolution as it is governed by its own mysteries or law. So these are all concluding my session. So this is the small thing towards the drug development and what way we can go for drug development, drug design, and which way we can cut out our time to develop the drug design, and which may what is the thing or what the way we can get the good drug for our to improve our quality of life. So these are all my what do you say, concluding my session, and thank you for listening very patiently, and yeah, thank you. Is there any question? I'm happy to take.
Thank you, sir. Your session has been both enlightening and inspiring. Any question from the audience side? Now I would like to kindly invite our chairperson to have some words about our session.
Good evening to one and all. Star has covered from starting from drug development, from basic things itself. Star has started. It go on the way like timeline of drug development, antimicrobial resistance, and accidental drug discovery, chemical modifications, drug design approaches. Likewise, he went to AI and the role of AI in drug discovery, drug design, like that. He has covered a lot of things. I think we may learn a lot of things from sir. Thank you, sir. Thank you for your golden words.
Thank you, Dr. Ronson. It's a raining of information that much of we are getting. I hope students get much enough knowledge about the presentation. Now the session open for question cash prize. This is the question I'm asking. Name of the AI platform used for drug discovery. நான் இப்போ ஒரு கொஸ்டின் கேட்குறப்பா அந்த கொஸ்டினுக்கு ஆன்சர் பண்ணீங்கன்னா உங்களுக்கு கேஷ் ப்ரைஸ். இட்ஸ் a very simple question. Name of the AI platform used for drug discovery. Anyone please? The name of the artificial intelligence platform used for drug discovery or design. Anyone please? Yeah. Please come forward. Oh.
Then only we can see, right, identity. So come on the stage and explain your answer.
There it is, de novo, designed by AstraZeneca's drug design.
Mr. Presenter. Okay, your answers, I think you answer something.
Name the microorganism which is resistant to all antibiotics. Name the microorganism which is resistant to all antibiotics. யாராவது சொல்ல முடியுமா ஆன்சர்? It's a very easy answer. எந்த மைக்ரோ ஆர்கானிசம் வந்து எல்லா ஆன்டிபயோட்டிக்லயும் ரெசிஸ்டன்ஸா இருந்துச்சு அப்படின்னு சார் டீச் பண்ணாரு.
It's my pleasure to call upon our esteemed chairpersons to honor our chief guest, Dr. Anson S. Marcoy.
Now I would like to call upon stage Dr. K. Gopala Satish Kumar, Professor and Organizing Secretary of this event, to honor our esteemed chairperson, Dr. C. Kannan. Next, I would like to call Dr. P. Perumal, Vice Principal, Sri Shanmugha College of Pharmacy, to honor our esteemed chairperson, Dr. D. Kumarasamy Raja. Thank you everyone for your kind gesture. Now the session is open for oral presentation and I request both the chairpersons to be on stage for evaluation.
Now session open for oral presentation. You can go for a catch block for a tea.
A warm greeting to the jury, students and professors present here. I am Sapna from Swami Vivekananda College of Pharmacy, Tirchangood, Passing B Pharmacy. I am here to present my study regarding on effect of Fertularia diamia extract on scopolamine-induced memory deficit in zebrafish through in silico, in vitro and in vivo approach. Next slide. So Alzheimer's disease is one of the memory deficit disease, so which leads to loss of memory, thinking and behavior which interferes with the regular day-to-day activities. So AD, that is Alzheimer's disease, is the progressive neurodegenerative disease which is due to the aggregation of amyloid beta plaques and intracellular aggregation of neurofibrillary tangles. So the now currently available drugs for treating Alzheimer's disease is donozepam and galantamine ribostigmine. So my plant is Percularia diamia. The reason why I have chosen Percularia diamia is because of this activity, which has been previously published in various research articles, like neuroprotective activity, antioxidant activity, anticholinesterase activity, and so on. The phytoconstituents present in this PD extract is that alkaloids, quercetin, especially quercetin, terpenoids, flavonoids, and glycosides, steroids, and several other phytoconstituents. And everyone used to do their research or their study on rat or mouse, but I have chosen zebrafish as an alternative model because of its accessibility, cost effectiveness, transparency, and behavioral validity and genetic manipulation. So now, aim of my study is to evaluate the neuroprotective activity of PD, that is Percularia diamia, my plant, on in silico, in vitro, and in vivo studies. In scopolamine, we used Alzheimer's zebrafish model. So coming to the objective, first collection, authentication of plant is done, and the next procedure is extraction of PD, and extraction is done by cold maceration process. After extraction, it is being continued by in silico, which includes both molecular docking and molecular dynamics. After in silico, I went through in vitro by using human neuroblastoma cells as cell line, and coming to in vivo studies. In vivo studies is performed by evaluating it by performing two major tests like the color biased appetite conditioning T-based test and inhibitory avoidance test. So coming to in silico studies, in silico is actually done to know the phytoconstituent present in the PD extract. So by using various software database like Impact, Dr. Duke's database, and several articles which have been published in PubMed. And finally, we retrieved like 65 chemical components in PD. And after retrieving, we used to find the 2D, 3D structures and canonical smiles by PubChem. So now the molecular docking studies is carried out by Autodoc now to find the interaction between the phytoconstituent chemicals and to the acetylcholinesterase. So coming to acetylcholinesterase, we used acetylcholinesterase because Alzheimer's disease is due to the decreased level of acetylcholine or decreased activity of acetylcholine. So by the acetylcholine is degraded by acetylcholinesterase. So by inhibiting the action of acetylcholinesterase, acetylcholine presence will be more. So we used the natural compounds that inhibit the acetylcholinesterase. The ligand is being collected from protein data bank. So now coming to the molecular docking studies, by investigating the phytoconstituent present through molecular docking studies, we came to know that quercetin, the most important chemical compound that has the higher docking score and the gliding energy score, that is minus 11.09 and minus 46.06. So since the 3D interaction, the first picture represents the 3D interaction of quercetin and the active site of acetylcholinesterase. The next one is 3D interaction of rivastigmine and active site of acetylcholinesterase. So coming to the molecular dynamic studies, this is performed and carried out by using Chromax. So Chromax is used to find the movements of the chemical compounds. So this is the graph that represents the RMSD, that is the root mean square deviation of quercetin and rivastigmine, and the RG plot for quercetin and then rivastigmine. So in vitro studies, the cell viability assay is first been performed by using the cell line called human neuroblastoma cells. So this is done to evaluate the neuronal viability and mitochondrial metabolic function by evaluating it by using M.G.R assay. So the tableau represents the in vitro cell viability assay on PD extract, which has been performed on the cell line human neuroblastoma. So at last we got that the maximal concentration, that is half maximal inhibitor concentration, is found to be 561.06 plus or minus 2 plus 2.7 microgram per ml. So now before slide we just saw about the cell viability. Now we are here to see about the inhibition assay, because the target is to inhibit the acetylcholinesterase. So the inhibitory assay, performing it by using Elman's method, it is found to be the half maximal inhibitory concentration is found to be 13.45 plus or minus 0.05 microgram per ml in rivastigmine. So in my ethanolic extract of PD, it is found to be 34.69 plus or minus 0.04 microgram per ml. So coming to in vivo studies. So in vivo studies is being performed by using the chemicals and reagents like scopolamine, this is the inducing agent, and rivastigmine, which is the standard drug which has been prescribed right now, and the experimental animal is zebrafish, and which weighs 500 mg, which has been divided into 5 groups, each containing 6 animals, 6 fishes. So the first group contains 6 fishes which is in controlled state, and the second group contains 6 fishes which is induced by scopolamine, and the third group has animals which is induced by scopolamine and treated with rivastigmine, and the fourth group has 6 zebrafish which has been induced by scopolamine and treated with 200 microgram of mg of PD extract, and the next one is treated with 400 mg of PD extract. So the in vivo studies is done by two major tests. The first one is color biased repeated conditioning T-maze test, and the second one is inhibitor avoidance test. So the procedure is, first the fish is kept in the holding tank for 7 days, and it has been fed by using micro catheter, plastic catheter and micro pipette. So the zebrafish is fed with rivastigmine and 200 and 400 doses of PD extract. So the experimental design is here, which represents before doing the experiments, conducting the experiments, the fish is kept for adaptive phase for 7 days and 7 days for pre-treatment phase and 4 days for the color bias repeated conditioning T-maze test and 2 was inhibitor avoidance test. So this is the result of color bias repeated conditioning T-maze test, which represents that the time spent by the fishes administered with PD 400 extract has a very good longer time spent when compared to scopolamine induced and controlled. This one denotes the number of fishes, which has a greater total number of entries when compared to control and scopolamine groups. This denotes the inhibitor avoidance test graph. So where the zebrafish that received the PD of 200 and 400 mg had significantly increased the latency time when compared to the control and scopolamine groups. So coming to the summary. So PD extract is mainly focusing on the constituent quercetin. We found that it has a strong binding effect, affinity towards acetylcholinesterase, the enzyme which used to break down the neurotransmitter acetylcholine that is essential for the memory and cognitive function. So this suggests the quercetin may have act as inhibitor of acetylcholinesterase. So it preserving the acetylcholine levels in the brain. So in vitro studies all about the protective neuronal dose dependent manner, suggesting the neuroprotective activity of PD. So in vivo studies is conducted to know to show that the PD extract has a very good memory performance and a cognitive function of zebrafish. So at last, by collectively, you can say that this PD extract can be used in future, or it can be used by using further studies. Thanks of reversing. Thank you, everyone.
Thank you for the presentation. It's a nice presentation and nice work also. It's a very basic question. Wherever you're using a plant, you should mention with italic. It's very basic in research. Okay. This is my question. How can we fix the dose, that means quantity of drug, like a standard drug for this?
So by performing various tests, so like the 200 and 400 mg, it has the property of anticholinesterase. So it was like we performed like many trials where you are giving 100 mg, 50 mg and 200. By that we concluded just took in only 200 and 400 mg, sir.
Okay, good.
Why you have compared with rivastigmine? Why you taken as a standard drug? On what basis?
Rivastigmine is the present drug which is being given for Alzheimer's disease. It is mostly prescribed drug. So by comparing it with rivastigmine, we can get a very good novel drug research, sir.
Okay. Okay.
Thank you.
Thank you, Swapna. Next, I would like to welcome Selva Bharati from Sri Shanmugha College of Pharmacy.
Students, please kindly make a note that you're only allocated 10 minutes for presentation. Just 10 minutes. Thank you.
Hello everyone, this is Selva Bharati, currently pursuing B.Pharm second year at Shanmugha College of Pharmacy. Today I am going to present my unpublished review article regarding the topic of the power of AI reshaping the toxicity studies and recent milestone in drug development. In this stage, I thank my guide Dr. R. Prema, Professor, Department of Pharmacology, Shanmugha College of Pharmacy. Let me introduce my topic first. Drug development process is not the easiest process, it's the lengthiest, costliest and complex process. It takes 12 to 15 years around, and around 1 to 3 billion US dollars will be expended for a complete drug discovery process, but till we expend also, the success rate of a new drug is only 13%. And most of the, according to our statistical report, out of 10 drugs, only 1 drug is getting marketed. Others are rejected in various drug discovery process, and 5 are mostly rejected in the toxicity issues. The success rate of the toxicity studies is only 30%. The pharma companies are now struggling to sustain their drug discovery process because of higher R&D cost and lower efficiency. For finding the solution for these issues, AI becoming the answer. My aim of the presentation is to highlight the transformative role of AI, artificial intelligence in drug, toxicity studies and recent achievement of AI in drug discovery process. Toxicity studies in drug discovery. The toxicity studies are crucial in drug discovery process to ensure the safety of a new drug. We check different types of toxicities like acute, chronic, carcinogenic, genotoxicities. For that, we use different methods to analyze the toxicities by in vitro, in vivo, in silico. In vitro, by using a cell culture or tissue culture or organ culture. In vivo, we use animal models and living organisms. In silicos, by using a computational techniques. The figure 1 representing the different models used in the toxicity studies, like cell, zebrafish, or animals or humans. The limitations of the current toxicity studies, first one is major specificity. Some of the drugs will not show any toxic effect in animal models, but they show toxicity in the humans. Example, we all know thalidomide disaster. Thalidomide is a drug which is used for anti-emetic drug, but it does not cause any toxicity to the animals, but it causes toxicity to the pregnant women. Around more than 10,000 infants were affected by this disaster. Ethical issues. The regulatory agencies are now increasingly advising the 3 principal: reduction, replacement and refinement. They are advising us to replace the animals by find any alternative way to find the toxicities, reduce the using of animals. The regulatory issues are now following. Next, less predictive values. Long-term side effects cannot be evaluated. Only we can find it only after the post-market surveillance. Time and expansion. When we are doing a toxicity studies in vivo, it takes high timing and consume more time and cost due to this uses of animals. We can use alternative way of in vitros, but we also consume less time and cost, but the efficiency and accuracy is very less. Now we are coming to the major topic of our my presentation, AI in toxicity prediction. The limitations of the toxicity studies can be minimized by using of artificial intelligence. There are various artificial intelligence tools are available in internet itself to find the toxicities. Like we know some of the AI tools like DeepTox and ProTox 2 are the 2 smart AI tools which is used for predicting the toxicities of our compound. The figure 2 representing the interface of the ProTox 2, which you can see the boxes on the interface. You can draw your chemical structure on this. The AI tool will predict the toxicity in few minutes. The AI algorithms analyze your chemical structure and the biological activity and interaction between the molecules and the biological targets and predict the toxicity of your compound. The figure 3 representing the stages of AI in toxicities. First, it collect all the data and it model it, convert into model. That model can be analyzed with comparatively previous toxicity studies and the compounds and predict the toxicity of your compound. The AI can automate the testing process and increasing the output and reduce the cost of your toxicity studies because the toxicity consumes more amount and time. Regulatory agencies are strongly required evidence for your safety of your drug. The AI toxicity reports will be one of your good secondary evidence for your compounds. These are the few AI tools I mentioned here, which is used in the drug discovery process. Alpha Toad for predicting 3D molecular of your structure, DeepChem is used for a candidate identification, Delta Vina for a drug and ligand binding affinity, Swiss ADME for predicting the properties of physicochemical properties of your structure, T-toxin products for toxicity predictions. Now I am entering the second major part of my presentation, the recent achievements of AI in the drug discovery process. DDR1 kinase inhibitor is a new drug designed by the pharmaceutical company. That company announced that the entire process from modeling to compound synthesis take only 21 days. It is one of the good achievements done by the AI only. And the BCG is a consulting agencies which make a survey and they said that 15 new drug candidates were entered into the preclinical stage, consumes less time and the average of drug required. And the groundbreaking as one of the biggest achievement of AIs in the year of 2023 February, a pharmaceutical company announced that they are entering the phase 1 clinical trials of a drug for a AI-based drug. They said that the complete synthesis to preclinical evolution they take only 30 months, but averagely it take around 6 years. You can see now how it is different. Where 6 years, where 30 months is where that's 2.5 years, lesser than 50%. Of time. This shows how the AI is going to change the entire drug discovery process. I come to my conclusion and concluding that the integration of pharmaceutical companies, artificial intelligence and toxicity studies reduce the time and the cost. And it reduce the using of animals also. And the AI based methods are also having some challenges like data, less amount of data and the regulatory agencies acceptance. And the remarkable 30 months of timeline of AI-based drug is enter the phase 1 clinical trials shows how AI going to incorporate with the pharmaceutical field. It's clear that AI is not just a part of our future, the AI is becoming our future. What? Okay, these are the references mentioned here, but around 50 plus articles were referred from a review article. Only I mentioned a few of them here. Thank you, that's all.
Okay, I think second slide, you have denoted that thalidomide toxic in animal studies. Okay, drugs will not show any toxic in animal studies. That's why thalidomide disorder studies happen. Actually, not that reason actually. Not only that, one more big reason.
But when we are evaluating thalidomide in animals, it not show any toxicity. Like with pregnant animal also, it not show anything.
Okay, but it show in humans also they have studied now.
Sir?
Phase 1, phase 2, phase 3 in humans also studied.
That time it's not identified. That time it's not identified. Later only we identified.
Actually, why this disaster is happened now? Mainly the studies it's not carried out in special populations. That means children. That is the reason for thalidomide disaster.
Yes, sir. Yes, sir. Human trial did not check to the pregnant women.
Actually, as per our clinical trial status, phase 1, phase 2, phase 3, we are not studied till now. We are not having any studies carried out in special population. That's why it's happened.
Yes, sir. But also I am saying that in animals we used pregnant animals also. Pregnanted animals like mice we used it, but it did not show any effect. That's a major issue. We did not use pregnant women in these clinical trials, but we are using animals. Pregnant animals, zebrafish was used at that time, but they didn't show any toxic effect. That's why I'm saying animals model sometimes not show any toxicity for certain drugs. This drug not, there is another drug called Vivox. It is used as an anti-inflammatory drug, but they didn't show any toxic effect in the animal models. They're showing now toxicity to the humans like heart attacks and cardiac arrest.
Is there any AI altered drug launched in the market?
Sir, I show in the conclusion achievements part, DDR1 inhibitor, kinase inhibitor. It is a drug is now in phase 3 clinical trial, I think. They entered in phase 1 clinical trial in the last February, and they now in June they entered into phase 2 clinical trials. Our literature service was said that much only. The phase 3 where they were entered or not, I don't know specifically because the literature is not available also.
Okay, good. Nice presentation.
Thank you, sir. Thank you for all.
Thank you, Selva Bharati.
Good evening to Nandal. Myself Ritika from the Erode College of Pharmacy, Pharm second year. My topic is development and characterization of effects in nodal lipid microsphere. So introduction, nowadays the major cause of death is infectious disease. So many drugs are existing for the infectious disease, but that is the very poor solubility in our body fluids. So the drug carriers plays a major role here. Many drug carriers are available, but the use of synthetic polymers as a colloidal carrier, it gets effects on incorporated drug during manufacturing of the formulation. So the alternative carrier substance are discovered, that is the liposphere carrier system. It has many advantages over other drug carriers, emulsion, liposomes and lipid microsphere cylinders. So lipospheres are used. We took the Cefoxime drug, that is the third generation cephalosporin antibiotic. It is used in the treatment of respiratory tract infections and urinary tract infection. In the BCS classification, it comes under fourth category, that is low solubility and low permeability. So it is very low solubility in our body fluids as well as the low permeability. So to enhance this property, we enhance this property by the formulating as liposphere. The material used in this Cefoxime as a drug, and cetyl alcohol, cetostearyl alcohol, and stearyl alcohol as a excipients, polyvinyl alcohol as a stabilizer. Method of preparation of liposphere, we prepare the liposphere in the melt dispersion method. That is, first we melting the lipid at 70 degrees Celsius and make the emulsify with surfactants, and we stir to make it homogeneity and cool at 20 degrees Celsius. So lipospheres are formed that by the liposphere, we evaluated some parameters, that is particle size and yield of liposphere and scanning study, encapsulation efficiency, drug content and in vitro release study. A particle size, by randomly selecting hundreds of particles, we seen under the microscope. And in liposphere, by the drying, filtering, weight, by the scanning electron microscope, we did morphology studies, and in vitro release study by the dialysis back diffusion technique. Results. We did for pure cefaxime as well as lipid coated cefaxime in the IR spectroscopy. Both were the same characteristics, so we conclude that there is no incompatibility between them. Formulation of cefaxime liposphere. We formulate it at 15 batches. Drug 100 mg we are used for 5 batch cetyl alcohol, another cetostearyl alcohol and stearyl alcohol. Polyvinyl alcohol 0.1% as a stabilizer. It is in vitro dissolution study. Cumulative percentage we did for 16 hours study. Second batch drug release content is very high as 82.95%. With acetyl alcohol we used 500 mg. With stearyl alcohol only the 72.86 is the maximum value that is released in 16 hours. In cetostearyl alcohol, 78.43 is the maximum value that is drug released in the 16 hours. So as a conclusion, cefaxime loaded liposphere successfully prepared by melt dispersion method. We evaluated the morphology, particle size, percentage yield, and endocrine efficiency, and in vitro drug release. The second batch of that is the best formulation we did. Percentage yield is 92.33% and particle size is 64.99. Entrapment efficiency is 95.50% plus or minus 1.23%, and the drug content 53.23%, and the in vitro release revealed 82.95% release in 16 hours. So cefaxime loaded liposphere demonstrate controlled drug delivery potential. It improves the bioavailability of lipophilic drugs, and these results will be helpful in future for in vivo studies. Thank you.
Thank you for the presentation. The sense of to identifying the particle size of lipospheres. Can you show that? In the result.
Particle size 4.9.
Result. Back. One more. Right. The first one, particle size analysis, determining particle size by observing randomly selected particle under a microscope. How can you identify with a microscope in a particle size? எந்த மைக்ரோஸ்கோப்ல நீங்க பார்ட்டிகல் சைஸ் பாத்தீங்க? இட்ஸ் a lab microscope, is that a specialized microscope?
Electron microscope.
There is anywhere the நீங்க ப்ரிப்பேர் பண்ணிருக்கிற அந்த லிபோஸ்பியர்ஸ் அதாவது போட்டோ வச்சிருக்கீங்களா? So that is the main core of your presentation. Liposphere prepare பண்ணிருக்கீங்கன்னு சொல்லிருக்கீங்க. அது போட்டோ வச்சிருக்கணும்ல. அந்த ஒரு ஸ்பியர் அதாவது நீங்க வந்து ஸ்மால் மேக்ரோ மாலிகுல்ஸ் எது ப்ரிப்பேர் பண்ணாலும் நீங்க சைஸ் எவாலுவேட் பண்ணணும். அதை தான் நீங்க கன்ஃபார்ம் பண்ணுவீங்க. சரியா? வெறும் மைக்ரோஸ்கோப் வச்சு நான் பார்ட்டிகல் சைஸ் கன்ஃபார்ம் பண்ணிருக்கீங்க. It's not really reliable first.
லிப்போஸ்பியருக்கும் லிப்போசோம்ஸ்க்கு என்ன வித்தியாசம்? வாட்ஸ் த டிஃபரன்ஸ் பிட்வீன் லிப்போசோம்ஸ் அண்ட் லிப்போஸ்பியர்ஸ்? எனி ஐடியா? வாட் இஸ் தி நான்-ஃபிக்கியன் டிஃப்யூஷன்? கன்க்ளூஷன்ல போட்டிருந்தீங்க நான்-ஃபிக்கியன் ரிலீஸை ஃபாலோ பண்ணுதுன்னு. ஓகே, தேங்க்யூ.
Thank you, Ritika. Now I call upon Juhi Chawla for her presentation. I kindly request all the presenters to occupy the seats in the front row.
Good morning, everyone. Good morning, sir. I'm Juhi Chawla from M.G.R College of Pharmacy. I'm pursuing third semester B Pharm. My topic is, sir, my title is Formulation Design, Development and Evaluation of Gastroretentive Cell-Defined Tablets by using natural polymers. The aim of the presentation study is to formulate and evaluate the cell-defined tablets by using natural polymers for the effective management of hypertension. Objectives. To formulate cell-defined floating tablets by using various ratios of natural polymers. To analyze the compatibility studies of drugs and polymers by using FTIR spectroscopic method. To study the influence of natural polymers on lag time. To study the effect of natural polymers on the release of cell-defined floating tablets. Literature plan of works. Literature survey, selection of drug and excipients, procurements of drug polymers and other excipients, pre-formulation studies, preparation of floating tablets by direct compression method, evaluation of tablets by various tests. Pre-formulation studies are carried out as per IP specifications and it was complied with the IP standards. Drug excipient compatibility studies are performed by Fourier transform infrared spectroscopic method. Pre-compression studies. As a pre-compression studies, we perform angle of repose, bulk density, tapered density, compressibility studies. Evaluation of tablets. For the evaluation, we evaluate the thickness, hardness, friability, average weight of the tablets. We have performed a swelling index for 15 batches of formulation in the time interval of 1 hour, 2 hours, 4 hours, 6 hours, 8 hours, 10 hours and 12 hours. Buoyancy studies of formulation, we calculated the floating lag time and the total floating time. In in vitro drug release study, we calculated in the time interval of 1 hour, 2 hours, 4 hours, 6 hours and 8 hours, 10 hours and 12 hours for the 15 batches. Conclusion. We give salinidipine drug in the form of floating tablets. It stays for longer period of time in our body and performs its activities. Due to this, it increases the bioavailability of salinidipine and reduces the frequency of administration. Thank you, sir.
So what do you mean by lag time?
Sir, நம்ம அந்த ட்ரக் டிசால்வ் ஆகிறதுக்கு நம்ம ப்ரிப்பேர் பண்ற மீடியம்ல நம்ம டேப்லெட்டை போட்டு அது ஃப்ளோட் ஆகிறதுக்கும் டேப்லெட்டை போட்டதுக்கும் நடுவில் உள்ள டைம் சார்.
எதுக்காக இந்த ட்ரக்கை செலக்ட் பண்ணீங்க? Why you have selected this drug?
இந்த ட்ரக்கை வந்து லோக்கல் ஆக்ஷனுக்கும் கொடுக்கலாம் சார்.
செலினிடிபைன் வந்து ஆன்டி ஹைப்பர்டென்சிவ் ட்ரக். இதுல எப்படி லோக்கல் ஆக்ஷன் இருக்கும்?
சார் இதுல இப்போ அல்சர் மாதிரியான டிசீஸ்க்கெல்லாம் கொடுக்கலாம் சார். ஸ்டொமக்ல ப்ரொடியூஸ் ஆகிற அல்சர்க்காக இதை கொடுத்தோம்னா 12 hours மேக்ஸிமம்.
What I'm asking now, why you have selected this drug? செலினிடிபைன் எதுக்காக செலக்ட் பண்ணீங்க இந்த ஃபார்முலேஷனுக்கு?
சார் ஸ்டொமக்ல HCl ஆசிட் இருக்கு சார். இந்த செலினிடிபைன் வந்து ஆசிட்ல சால்யூபிள் ஆகும் சார் ஈஸியா.
Okay.
Tell me your title first.
Formulation design development and evaluation of in vitro.
So you prepare your tablet with natural polymers, isn't it? I don't find any tabular column with the active pharmaceutical ingredient, the name which is containing the natural polymer like that.
Sir, sorry sir, I forgot to. Sir. The polymers I used are xanthan gum.
That is the first one. If you say formulation, you should show the product first.
Yes.
There is no product, there is no composition, ingredients. Then using natural polymer. What is natural polymer? What is the name of the natural polymer you have used?
Xanthan gum, gar gum, acacia, sir.
Where it is?
So, yes.
Okay.
Thank you, sir. Thank you, sir.
Thank you, Juhi Shavla. Next, I would like to call Sanjay to present.
Good evening to all. Good evening, sir. My name is Sanjay. I am currently pursuing B.Pharm third year in Shanmugha College of Pharmacy. So my topic is about the antidepressant like effect of synovial or chronic unbearable mild stress-induced depression is mouse model. So first of all, we have to know about the depression. So according to the World Health Organization, so the aim of the study is to investigate whether the phenomenon has an antidepressant-like effect of depression induced by the chronic unbearable mild stress-induced stress and explore the underlying molecular mechanisms. And the objective is to study the effect of phenomenon on depressive behavior and detect the levels of brain serotonin or epinephrine levels, and also the pro-inflammatory cytokines such as the interleukin 1 beta, interleukin 6 and tumor necrosis factors in mice model. So the materials which are used is 30 ICM mice. So ICM mice is the strain of the albino mice, and the duration of the study is the 30 days. So the 30 mice models are randomly grouped into 5 groups, and each group containing the 6 animals, and the control group treated with the unrest and saline, and the model group which is CUMS induced and the phenomenon treated low dose of 30 mg per kg and high dose of 100 mg per kg and the standard groups of fluoxetine 20 mg per kg. And the parameter assessment was performed is the behavioral parameter is sucrose preference test, tail suspension test, post swimming test, and the biochemical parameters tested was brain serotonin and norepinephrine levels and the pro-inflammatory cytokines levels. And the stressors which are used performed in the test to induce the CUMS are damped shortest beating for 12 to 15 hours and the exposure of the foreign object in the cage for 1 hour and the water and food depression and the inversion of light and dark cycle and the cage tilting at 45 degrees Celsius, 45 degree for 12 to 15 hours and the tail clipping and intermediate white noise for 85 decibel and the test was performed in the alternative days. In results, the sucrose preference test was carried out every week and the sucrose preference is calculated by the formula preference value is equal to sucrose intake divided by sucrose intake plus water into 100. In depressed state, the mice should avoid the sucrose on India. As compared with the control group, the moderate group significantly decreased the sucrose consumption. On the treatment with the phenomenon, the sucrose consumption was increased as shown in the graph. In forced swimming test, the mouse is floated in the water in upright position and the immobility time was recorded and the immobility time of the mouse model was significantly increased as compared with the control group and however on treatment with the phenomenon and the fluoxetine, the immobility time was shortened. The same the tail suspension test was carried out by hanging the mouse about 25 centimeter and the test and the immobility time was recorded for 6 minutes and the 1 minute for adaptation and the remaining 5 minutes was recorded. The experiments were performed at least 3 minutes. The immobility time of the mice model is increased in the model group and however on the phenomenon and fluoxetine treatment the immobility time was reduced. The norepinephrine and serotonin levels was detected by the ELISA test. So it was performed by after 21 days. The hippocampus was started and the norepinephrine and the serotonin levels was expressed in nanogram per gram and the experiments concluded that the norepinephrine and the serotonin levels in the model group was decreased and on treatment with the phenomenon the levels of the norepinephrine and serotonin was increased. And in the pro-inflammatory cytokines, the levels of the interleukin 1 beta, interleukin 6 and tumor necrosis factor in the hippocampus groups were measured by the ELISA assay and the levels of the pro-inflammatory cytokines was increased in the model group. On the treatment with the synopsin and the fluoxetine, the pro-inflammatory cytokines was decreased. In conclusion, the phenomenon relieved the CUMS induced depression by increased sucrose preference and shortened the immobility time in forced swimming and tail suspension test and also the phenomenon increased the norepinephrine and the serotonin levels and decreased the pro-inflammatory cytokines such as the interleukin 1 beta, interleukin 6 and tumor necrosis factors. And also the phenomenon, it was concluded that the phenomenon exerts an antidepressant-like effect on mouse model induced by the CUMS. To provide the more reliable theoretical basis for clinical treatment of depression with the phenomenon, must research needs to be carried out in the future. So this is the reference. Thank you, sir.
What's your main aim of this study? What you are going to conclude from this study?
So to identify the antidepressant effect.
For?
So to study the antidepressant effect in mice model induced by the chronic unpredictable mild stress.
Why you have selected the ICR type mice?
So because ICM is strain, which is the strain of albino mice, so it is obtained from the Institute of Cancer Research. So why I selected the ICM mice? Because the albino, compared to the albino mice, so it is more reproducible and cost efficiency, and also and have greater weight compared to the albino mice. So I selected these ICM mice.
Go to next slide. So the treatment schedule in the group 2 and group 4 and group 5, how did you fix that 30 mg, 100 mg, 20 mg?
30 mg is the minimum dose and the 100 mg is the maximum dose.
So straight away you selected 30 mg, 100 mg.
So to calculate the minimum and maximum.
Why don't you select 20 mg? Why don't you select more than 100 mg?
So which leads to the toxicity. So
that is the point of my question. So you have to do the toxicity before selecting the dose for animals.
Sir, I performed the acute oral toxicity, but I did not include that because of the time constraint.
Okay.
Thank you, sir.
Thank you, Sanjay. At last, I would like to welcome S. Nandini to present.
We can choose the visitor albino rat. It is old, 6 to 8 weeks old rat are taken, and its weight is about 160 to 180 gram. That was that was housed and maintained by the central animal house, and maintain particular temperature, relative humidity, and light and dark cycles. Then animals were fed with the commercial pellet diet. We can provide the food as a pellet diet substance. As per the protocol, the study was approved by the IAEC, which means Institutional Animal Ethical Committee, and where it accordancy with the CPCSCA guidelines, which means Committee for the Purpose of Control and Supervision of Experimental on Animal. From acute toxicity study, we can perform this acute oral toxicity study by as per OECD guidelines, which means Organizational Economic Cooperation and Development 423 guidelines. And the rat were first fasted overnight and some water only given. The rats are grouped into four. In the four group have 3 animals each. First, the extraction was administered orally. with the different doses like 5 mg per kg, 50 mg, 30 mg, 2000 mg of injected to the rat. Then we can observe the mortality and toxic symptoms such as behavioral changes, locomotory activity, convulsion, salivation, diarrhea, sleep, etc. This study was studied by 14 days. First day we can observe the activity every 30 minutes, and next day and day before we can check the activity of every 4 hours. Next. As per result and discussion, these are a response. Before this response are normal. After injected this extraction, it is also normal. Next. Coming to conclusion, that lethal dose of 50 of Artemisia vulgaris extraction was determined as per OECD guidelines 423 for fixing the biological evaluation. It was observed that the alcoholic extraction was not lethal to the rat at 2000 mg per kg. Hence, the dose fixed for the study as low dose as a 200 mg per kg and then high dose as a 400 mg per kg. From the result of acute toxicity study, it was performed that administration of different dose of Artemisia vulgaris extraction to the Wistar albino rat did not cause any drug-related toxicity or mortality in the animal up to 2000 mg per kg. Reference. That's all.
Nice presentation.
Thank you, sir.
நீங்க ஒரு பிளான்ட்டை செலக்ட் பண்ணிருக்கீங்க, அதுக்கு வந்து டாக்ஸிட்டி ஸ்டடி பண்ணிருக்கீங்க இல்லையா? So what is the purpose of selected that particular plant?
Sir, because next slide. Sir, it treat many diseases, rheumatoid arthritis, diabetes, infertility, impotency. So we choose
பிளான்ட் இல்லமா, எந்த பிளான்ட் எடுத்துட்டாலும் அதுக்கு ஏதாவது ஒரு ஆக்டிவிட்டி இருக்கும் சரியா? எல்லா பிளான்ட்டுக்கும் ஒரு ஆக்டிவிட்டி இருக்கும். பர்டிகுலரா இந்த பிளான்ட் செலக்ட் பண்றதுக்கான பேக்ரவுண்ட் ஸ்டடி என்னன்னு கேட்கிறேன். வாட் இஸ் த பர்பஸ்?
Extraction yield is high, sir, so we choose.
Extraction
yield.
எக்ஸ்ட்ராக்ஷன் எல்லா பிளான்ட்டுக்குமே ஈல்டு கொடுக்குமே, கொடுக்காமல இருக்காது. ஒரு பிளான்ட்டை செலக்ட் பண்ணியிருக்கீங்க சரியா, வந்து பவுடர் பண்ணி எக்ஸ்ட்ராக்ஷன் பண்ணிருக்கீங்க இல்லையா? ஸோ த ஏரியல் பார்ட் ஆஃப் பிளான்ட் அப்படின்னா பிளான்ட்டோட மேல் பகுதின்னு வச்சுப்போம். இது எங்கேயாவது ஆத்தென்டிகேட் பண்ணிருக்கீங்களா? ஆத்தென்டிகேட் பண்ணீங்களா அந்த? ஸோ பிளான்ட்டை செலக்ட் பண்ணும்போது ஆத்தென்டிகேட் பண்ணாம எப்படி நீங்க ப்ராஜெக்ட் பண்றீங்க? Coming to the next question. ஸோ அந்த எக்ஸ்ட்ராக்டை ஓரலா கொடுத்துருக்கேன்னு சொல்லியிருக்கீங்க சரியா? அது எப்படி கொடுத்தீங்க? எக்ஸ்ட்ராக்ட் அப்படியே எடுத்து கொடுத்துட்டீங்களா? ஏன்னா எக்ஸ்ட்ராக்ட் நீங்க வந்து சாக்ஸ்ட்ரேட்ல யூஸ் பண்ணி கடைசியில வெளியில எடுக்கும்போது வந்து ஹை விஸ்கஸா இருக்கும். ஸோ அது எந்த மூட்ல கொடுத்தீங்க? அது வேற சம்டைம்ஸ் வந்து இன்ஜெக்ட் பண்றேன்னு சொல்றீங்க, ஓரலா கொடுக்குறேன்றீங்க, இன்ஜெக்ட் பண்றீங்க. எப்படி அந்த இதை கொடுத்தீங்க? ஏன்னா எக்ஸ்ட்ராக்ட் ரா எக்ஸ்ட்ராக்டா எடுக்கும்போது அது ஹை விஸ்கஸா இருக்கும். ஸோ அது ஏதாவது மிக்ஸ் பண்ணி கொடுத்தீங்களா இல்லை அப்படியே எடுத்து கொடுத்துட்டீங்களா?
மெத்தனால் கூட ஆட் பண்ணி.
மெத்தனால் ஆட் பண்ணும்போது அது ஒரு ஃபார்மகாலஜிக்கல் ஆக்டிவிட்டி ப்ரொடியூஸ் பண்ணாதா? சரி,
தமிழ் நேம் என்னமா? இந்த பிளானோட தமிழ் நேம் அது தெரிஞ்சிருக்கணும்ல. Okay.
Thank you, sir.
Thank you, Nandini. Finally, today's session has come to an end, and I thank both the evaluators for your kind participation. As we drew the curtains on this eventful day, I want to extend my heartfelt gratitude